and we hope that it's helpful to you. We know these are really tough times and we want to be able to get the information out to you. Our presentation is entitled What to Expect When You're No Longer Expecting, because we always talk about the 3 trimesters, but there really is a 4th. So that time in the postpartum period is really critical, and we want to equip you with the tools and the skills of what to look out for, and empower you to speak up and speak to your providers. For those of you who haven't conceived yet, this is a little bit ahead for you, but it's never too early to start doing your research and learning more, and preparing yourself. And also, for those who've already gone through this, you may have future children, or you can take this information with you and share it with another woman. So today is Maternal Health Awareness Day. It's easy to remember, 1, 2, 3. So I really do thank you all for being here with me today. Everyone is muted right now. If you have any questions while myself or the students are speaking, please feel free to send it in the chat and I'll address them as quickly as I can. And we will have some Q&A with some really amazing guest speakers. If there's a problem with IT or any issues at all, please also feel free to send it in the chat, or if you're having trouble, let me know. So we're working with the students from the Hackensack Meridian Health School of Medicine, the OBGYN Student Interest Group. So these students are first, second, and third years, primarily first and second, who are interested in a career possibly in obstetrics and gynecology. These students are remarkable. They're bright and excited, and I'm very lucky to work with them. So I'm glad you're going to meet some of them today. So this is just a list of the advisors and the student leaders in the Hackensack Meridian Health School of Medicine OBGYN Student Interest Group. We actually are an official Acog student chapter, Acog, the American College of Obstetricians and Gynecologists. Mountainside Medical Center is the hospital that I work for, and also the co-sponsor of the event in conjunction with the medical school today. So it's located in Montclair, New Jersey. It's a premier local maternity center where there are board certified obstetricians and certified midwives. We have 24/7 anesthesiologists and certified nurse anesthetists, and we do deliveries 32 weeks and above. So when I see my patients, I tell them the larger hospitals like Barnabas and Hackensack and Newark Beth, they are equipped to do deliveries under 32 weeks in the severely premature babies, because those babies typically have to stay for months at a time. However, we are a smaller community hospital, so even though we're all equipped doctors to deal with high-risk problems, and we deal with plenty of high-risk obstetrics, we try to reserve deliveries to 32 weeks and above. We have a level 2 special care nursery, so we have the tools as far as ventilators and feeding tubes and oxygen and phototherapy, as well as antibiotics and pretty much everything you can imagine. But there are certain things that we do not have, and that you can discuss with your provider, current or future. We have 24/7 neonatologists, so that is the highest level of pediatrician, the same that are at the higher tertiary care facilities. We have special care nurses and internationally certified lactation specialists, the best that I've seen in the area, and I've worked at several hospitals, and we will work with one of them today, and she's a wonderful woman. We do offer parent education classes, and now everything is virtual. So even though everything is scary during the COVID times and pandemic, you can call this number, and you can also go online. The hyperlink is below, and you'll all be receiving a copy of the presentation if you registered, and you can go online to register for any of the classes. We have the Labor of Love program, and the classes are actually free at this time. So you can take a virtual tour. They have prepared childbirth classes, becoming a parent class, and the breastfeeding classes, bar none. Like that, it's amazing. And that's something that maybe your obstetrician won't be able to help you with as much. So these internationally certified lactation consultants run the breastfeeding class, and when things open back up again, they'll resume the in-person breastfeeding support group. A special thanks and shout out to our community health manager, Flore Cruz Serpa. Without her, this event would not be possible. I've worked with her now for 3.5 years, giving talks throughout the community, and I'm very fortunate to know her. She does a lot for so many people, and I just wanted to recognize her today. And also a special thanks to the Director of Marketing at Mountainside, Kara Marabawal, because she is the woman who also put the event together and really helps to get a lot of helpful education out to women in the community. So today's agenda, I'm giving a little introduction for Acog and Maternal Health Awareness Day. Our students will talk about the postpartum visit, as only approximately 40% of patients even attend their postpartum visit, and it's really important that you do that. So we want to encourage you, and we're going to talk about why it's so important. Then I'll be available for some questions. We'll take 5-minute breaks in between. So if you feel like a topic is not important to you, we are going to try to stay on schedule as much as possible. So feel free to step out, get something to eat, take a break, and jump back on. But if all these topics are wonderful, so we hope you're able to stay on for the entire seminar. We're going to speak about maternal mortality, and we're going to have a question and answer with Dr. Montemiro, and then 11:20 to 11:25 a break. Then we'll speak about perinatal mood disorders. We're very fortunate to have a representative from Postpartum Support International, a local clinical psychologist. We'll have another break, speak about breastfeeding, and as I mentioned before, Barbara Leonardo is our internationally certified lactation specialist. She will be there to speak with us, and then we'll have another break. And lastly, I'm going to do a very special interview with a near and dear patient of mine who once I asked her to share her story because she has a lot of pertinent information, and I really think who better can tell you but a woman who's just gone through it. So she's open to questions, and I'll be interviewing her at the end of this discussion. So just some Zoom etiquette. Please feel free to leave your video on during the seminar so we can have a robust, engaging experience. If you prefer to mute your video, that's totally acceptable. We know that we're all having a busy Saturday. You can come and go, as I said before. If you find some topics more interesting than others, just please keep yourself on mute unless you're called upon for a question, just because background noise can be distracting to the other learners. If you wish to ask a question, send me a question through the chat and I'll address them. And if you during the Q&A session, however, we'll have you try to raise your hand. You can also send me through the chat if you're like it to be anonymous. And we just want this to be a fun morning, and we want everyone to learn and really get something out of this. So Dr. Daniela Montamiro is our guest speaker, and I'll give a brief bio when I introduce for the Q&A for each of the doctors. Dr. Alexis Menken, she's our clinical psychologist, and Lori Leonardo is our international certified lactation consultant. So the American College of Obstetricians and Gynecologists, this is the mission and vision statement. It's directly from our website. The American College of Obstetricians and Gynecologists is a membership organization dedicated to the advancement of women's healthcare and the professional and socioeconomic interests of its members through continuing medical education, practice, research, and advocacy. Basically, Acog is an organization that oversees everything that obstetricians and gynecologists do. We go to the national office in Washington, we go to the Capitol, we speak to legislators on your behalf, we fight for women's rights and advocate for women. We are nonpartisan, and we really try to look out for women, and we also hold ourselves accountable by having committees and practice bulletins and committee opinions to make sure that we're practicing evidence-based medicine. The Acog core values, this is also from the website, so I don't need to read it to you, but we really are trying to give access to women, for all women, in a high quality, safe manner. Acog oversees residency education and medical student education, and again, advocating for women and members is really important. So Acog was founded in 1951. There's almost 60,000 members, and the country is divided into 12 districts and 98 sections. So we're in District 3. Our section includes New Jersey, Pennsylvania, and Delaware. We have an international relationship with the Dominican Republic. So each district has one or more countries outside of the United States that we partner with to help them, educate them, and we learn from them as well. And so Dominican Republic is our country. I go down to DR at least once a year, and I give seminars. I started a simulation lab in the Dominican Republic, and I've established a great relationship with the wonderful doctors down there. I've worked with fetal surgeons from Venezuela, and given multiple talks on inductions and patient safety, and trained. I've been working in international healthcare for about 12, well, now I'm dating myself, about 12 or 15 years or so. And as far as Uganda, Ghana, Haiti, and the Philippines. So I do surgical outreach programs, and also training nurse midwives in postpartum hemorrhage and shoulder dystocia. So it's really important that we all help each other out. Acog works with other organizations like the New Jersey OBGYN Society. I'm the president-elect. We have a society of our own that focuses on just issues in New Jersey, A1, the CDC, and they form guidelines for practice. We're forming advisory boards and perinatal collaboratives and maternal mortality review committees, because it's really important that we're watching why women are still dying in healthcare and from dying in childbirth, and why, how we can prevent maternal deaths, and how we can work on limiting maternal morbidity as well. The Acog Executive Board, these are just some names that you may see if you go on the Acog website. And I am on the District Advisory Committee as well, so I can serve as a resource if you ever have any questions. Okay, the Acog website was just redone. It's wonderful, and they actually have a patient-free search engine now, so you can go right on right here to this hyperlink. So women's health /ACOG, excuse me, and you can type right into the search bar questions that you have. We all know that Dr. Google is not your friend, right? We all want our patients to be empowered. We want you to educate yourselves and read up and ask questions. There's so many times that I have patients who don't know what surgeries they had, or even what, if they had cancer, what type of cancer they had, and that's very scary and sad for me, because I want us as providers to be explaining to the patients what's going on with them, what's going on with their babies. And if you know, you don't ask, sometimes we can assume that we assume that you understood. So please don't be afraid to speak up. But we want you to read evidence-based guidelines. We want you to read good sources, because not all the resources we know on the internet are equal. So please refer to this at any time. I know I will print out information from ACOG, or I will refer patients to this all the time, so that you're receiving good information, and you're and then I'm advocating for my patients to be empowered in their care. We really want you to take an active role in your care. So Maternal Health Awareness Day is why we're all here today. 1, 2, 3, it's easy to remember. 4 years ago, Maternal Health Awareness Day was established in Acog District 3 to educate on maternal health initiatives. So the initiative of AIM, these are bundles that we've come together and formed on postpartum hemorrhage and pre-eclampsia, instructions on how to tackle these very serious conditions. But if very important people got together, and very smart people got together and said, you know, let's just make this standardized so that everyone is doing the same thing, and it's based on evidence, so we can help decrease the risk of maternal morbidity and mortality. So today, the whole point of Maternal Health Awareness Day is for everybody on this day to get together and do an educational activity. There are tons of events going on. Because it's on a Saturday, a lot of people made this like Maternal Health Awareness Week. So I really appreciate you guys giving up your Saturday morning for us. I hope that you feel that it's worth it. And on this hyperlink that has other events going on this week and next with Senator Cory Booker, Tammy Murphy did an event last week. There are Senator Vitale. There are people who are trying to advocate for physicians and advocate for women's rights. You can learn more about legislations. You can learn how to contact your local representatives as well. Again, ACOG is bipartisan. We're just trying to advocate for women's health here. So I really thank you for all participating today. Each registrant will receive a package, including a folder containing a variety of resources from Acog directly. I'm gonna have the folders all together for you, and we'll send them out next week. Postpartum Support International is a wonderful organization that I've learned a lot from, and they're really well known, and the International Board of Certified Lactation Consultants. So everyone will get information about breastfeeding, because that can be one of the most challenging parts of being pregnant and having a baby. So you'll receive information that Lori and the students have gathered. The handouts from today's presentations and my presentation will be in there. The Save Your Life Post-Birth Warning Signs refrigerator magnet. This is a checklist of things that you can look out for. This is for everybody, will receive this as well. A small journal, so you can jot down things that are possibly bothering you to discuss with your doctor at your next visit. Or if you do find that you're suffering from intrapartum or postpartum depression or anxiety, you can jot down your thoughts. Silicone bands, we made these for everybody. Remember, you made a miracle is what it says on there, and that was the students who made a wonderful, the game came up with that idea. And then there's some other small tokens. So my card will be in there with information. These are links to some of my contact information and my office information. If you have any questions after the talks, you can reach me. So we're going to get right into the postpartum visit. So I'm going to stop sharing and allow the our postpartum visit speakers to share their screen.
Let me just share. Can everyone see the slides? Or is it in presenter view?
We can see it. It's good.
Okay. So my name is Nicole Acero, and I'll be joined by my colleagues Sonali Gupta and Isaac, and today we'll be talking about the importance of the postpartum visit and what to expect during your fourth trimester. So the postpartum visit is the time when your body recovers from pregnancy and birth, and it generally lasts about 6 weeks. And so the visit is a medical checkup you get after having a baby to make sure you're recovering well from labor and birth. And postpartum care, as Dr. Parisi just said, is important because new moms are at risk of serious and sometimes life-threatening health complications. So too many new moms have or even die from health problems that may be prevented by getting postpartum care. And we'll talk more about that at the maternal mortality section later today. It's also important that you make a postpartum care plan with your provider during pregnancy and talk to your provider about your postpartum care team. So when should you see your provider? You should be having your first visit within the first 2 weeks and then again at 6 weeks. C-section patients should see their provider at 1 to 2 weeks for an incision check. Vaginal delivery patients should be seen at 2 weeks, and then all patients should be seen again for a third time at 3 months for your annual checkup. So we'll just go through what you might discuss with your provider during the postpartum visit, and I'll start with your body in the postpartum period. So these are some common postpartum symptoms, and I'll go through each one of them, and they'll also be listed in the resources that you'll be getting. So first, vaginal bleeding and discharge. Initially, your discharge will be red, and that is because it contains blood, shreds of tissue, and the mucus layer that lined your uterus during your pregnancy. Then over the next 3 to 4 days, the amount of discharge will rapidly taper, and it'll change to a reddish brown color. It can also smell quite bad. Around 10 days, some women experience heavier bleeding during subinvolution of the placenta, so don't get nervous if that happens to you. And then in the 2nd to 3rd week postpartum, the discharge will become thicker and more yellowish white in color. Secretions typically stop during the 5th or 6th week postpartum. Then you might experience some cramping or what's called after pains. Your uterus is contracting and relaxing as it shrinks back to its normal size. So that's why you're experiencing those cramps, and it may feel like menstrual cramps or labor contractions. And this occurs during the first 2 to 3 days of postpartum. During the first 12 hours postpartum, your uterine contractions will be regular, strong, and coordinated, and the intensity, frequency, and regularity of contractions typically decrease after the first day. It's more common in women who have given birth before, and also more common during the first few days of breastfeeding. And for pain relief, apply a heating pad to your abdomen. If you need to take an over-the-counter pain reliever, ibuprofen would work better. Another symptom that you might experience is pelvic organ prolapse. So the pelvic organs are the vagina, uterus, bladder, urethra, and rectum, and these organs are held in place by the muscles of your pelvic floor and layers of connective tissue. And the pelvic floor is a set of muscles between the tailbone and the pubic bone. So during pregnancy and vaginal childbirth, these things weaken muscles of your pelvic floor. And so pelvic organ prolapse is when tissue and muscles can no longer support the pelvic organs and they drop down. And I know that sounds quite scary, but many women have no symptoms and are diagnosed by their physician during a physical exam. Women with symptoms may experience any of these following symptoms. You might also experience some bladder problems from stress incontinence due to lost leakage of urine, and it could be a symptom of a problem with your pelvic floor, as we just talked about. Urge incontinence, where you feel like you have to urinate very frequently and that you have a very small bladder or that you can't hold it in. Urinary retention. After delivery, your bladder capacity is increased, which can lead to overdistension and incomplete emptying of the bladder. And when you do urinate, you may feel some pain or burning. UTIs are also common during this period. Pelvic floor exercises like Kegel exercises strengthen the muscles surrounding the openings of the urethra, vagina, and rectum. And doing these exercises regularly may improve incontinence and may slow the progression of pelvic floor organ prolapse. So I would talk to your provider or a physical therapist about how to do these correctly. Constipation is another symptom that about 5% of pregnant women overall have some degree of having at 3 months postpartum. Operative vaginal delivery and lacerations involving the anal sphincter increase your risk of constipation, and don't be shy in telling your provider if you are experiencing constipation during your postpartum visit. To manage the constipation, drink plenty of fluids, take short walks as soon as you can, eat foods high in fiber, we'll talk more about that later, and ask your provider about a stool softener or laxative if needed. Hemorrhoids are sore, swollen veins that appear due to the intense straining that you do during labor, and it's a common complaint postpartum. If you develop varicose veins in your vulva or hemorrhoids in or around your anus during pregnancy, they may worsen after your delivery, and straining when you have a bowel movement can make hemorrhoids worse. So to reduce swelling and itching, medicated sprays or topical ointments can help. Dry heat, sitz baths, cold witch hazel compresses. But again, talk to your provider to see which would work best for you. Breast soreness is another symptom. We'll have an entire breastfeeding section later in the day, but I'll just go through it briefly right now. Engorgement is when your breast milk comes in and your breasts may feel very full, hard, and tender. Breastfeeding often helps ease the pain and pressure. Cold packs may provide relief. If you are not breastfeeding, wearing a tight-fitting bra may help stop milk production earlier. And for women who are breastfeeding, you may experience some nipple pain. This can be improved with proper breastfeeding techniques. Your period should typically return in 7 to 12 weeks in non-lactating mothers and 36 months in breastfeeding mothers. And just because you are not menstruating does not mean you are not ovulating. Pregnancy could still occur, and we'll talk a bit more about pregnancy in a few minutes. On average, women lose about 10 to 13 pounds immediately postpartum due to the loss of amniotic fluid and blood, as well as, of course, delivery of the infant and placenta. You may lose an additional 9 pounds during the postpartum period at 6 months because of the excretion of fluids and electrolytes accumulated during pregnancy. I'll move on to talk about sexual health. So it is safe to resume sexual activity when you are comfortable and bleeding has diminished, but it is very important that you resume sexual activity only after being cleared by your physician. And this is because you could still be at risk of infection if you have any tears. The median time for resumption of intercourse after delivery is about 6 weeks. Normal sexual response returns at 12 weeks, but remember, everyone is different. Sexual desire and activity can vary among women. During sexual activity, if milk ejection is a concern, nursing the baby before sexual intimacy can help. Breastfeeding suppresses estrogen production, and estrogen produces lubrication, so you may experience vaginal dryness. Water-soluble or silicone lubricants can help, pelvic floor therapy can help, and it's common to feel discomfort or pain the first few times you have penetrative sex after childbirth, but don't push yourself beyond that. Remember to go slowly and be gentle with yourself. I'll now hand it over to Sonali, who will talk about contraception.
Thank you. So next, we'd like to talk about postpartum birth control. The reason that this is important, like Nicole mentioned, is that even though you may not be menstruating, you're still ovulating. So it is possible to get pregnant very soon after having a baby. Using a birth control method in the weeks after you have your baby can help you avoid an unintended pregnancy. But it is important to note that you should not use an estrogen-containing birth control before 6 weeks postpartum, nor during breastfeeding. So on this slide, you can see you have several options for birth controls that range from long-acting reversible options, injections, hormonal options, barrier methods, timing, or even permanent sterilization options. And like I said, some of these options are not viable if you're breastfeeding. So on the next slide, we can get into which ones are options for that time period. So things to consider when you're choosing a birth control postpartum is one would be timing. So some of these methods can be started immediately after childbirth, while others may require you to wait a few weeks. During breastfeeding, you cannot use an estrogen-containing birth control. So some of your options include either a copper or progesterone-only IUD, the progesterone-only pill, condoms, abstinence, the lactation amenorrhea method, the rhythm method, although these are less desirable. And those are your only options during breastfeeding. The Depo-Provera injection and Nexplanon implants are technically progesterone only, but they are they're not recommended while you're breastfeeding because they can decrease your milk supply. Again, you cannot use an estrogen-containing birth control while breastfeeding. And another thing to consider is the effectiveness of your birth control. The method you used before pregnancy may or may not be the best choice to use after your pregnancy. So going along with this, next we're going to talk a little bit about birth spacing. Birth spacing, also called the interpregnancy interval, refers to the time between one live birth and the start of your next pregnancy. Birth spacing aims not only to maximize your level of wellness during your pregnancy, but also between pregnancies and your child's well-being as well. Research suggests that beginning a pregnancy within 6 months of a live birth is associated with an increased risk of premature birth, placental abruption, and low birth weight. So to reduce the risk of those complications and other health problems, research suggests waiting 18 to 24 months, but less than 5 years after live birth before attempting your next pregnancy. But as we all know, even with careful planning, you can't always control when conception happens. So it's extremely important to talk to your provider about family planning and contraception options to find what fits best with your needs and your beliefs.
Hi, I'm Isaac. I'll be taking over for diet, exercise, and special precautions. So I'm not getting paid enough by anyone to be proposing a specific food guide or a diet. I'm not an Instagram influencer. And this is not the time to add more new changes and stress to your life. The best I can suggest to you is try to eat a healthy diet with lots of vegetables and lean proteins throughout the day. And if you want more specific instructions, I highly suggest going to one of our nutritionalists. But finally, if you want to keep one thing in mind, avoid diets and medications that promise rapid weight loss. But what could you eat? To encourage healing, I suggest 3 things. Protein to help rebuild tissues damaged during labor through nuts, Greek yogurt, nut butters, jerky. Iron to prevent postpartum anemia, like dark leafy greens, beans, sweet potatoes. And fiber to prevent postpartum constipation, like oats, fruits, beans, popcorn, nuts, and seeds. If you're considering breastfeeding, there's some other things you need to keep in mind. As a rule of thumb, breast milk contains proteins, calcium, vitamins, and a lot of water, so you're going to need to have extra of that to make sure you have enough for yourself and the baby. So you should try to drink 8 to 10 glasses of water a day. This doesn't necessarily mean getting a milk jug of water and start chugging, but making sure you're eating very moist foods like fruits and veggies. And the CDC also recommends you getting an additional 500 calories a day. And there's some things you also need to keep in moderation or keep in mind. For caffeine, you can have up to 2 servings a day. For alcohol, you can have up to 1 drink a day. And on the side, I have that little graphic of what's considered a drink of alcohol. And you need to moderate or limit seafood for similar reasons for why you have to limit it during your pregnancy. If you were a gestational diabetic, you have a 30 to 70% lifetime risk of developing type 2 diabetes, so you need to consider eating a carb-conscious diet. And additionally, if you were a gestational diabetic, you're very likely to become a gestational diabetic again if you become pregnant again. If you're just gestational diabetic, you'll have to be screened at 8 to 10 weeks with a 2-hour, 75-gram glucose tolerance test. Then if it's normal, annually for each 3 years with A1C. If it's all normal, you can return to routine screening. If you had high blood pressure during your pregnancy, you should consider some lifestyle changes and decreasing salt because, once again, you have a higher chance of developing high blood pressure permanently and developing it again during subsequent pregnancies. Exercise. So when can you get out of bed? Generally, when you feel like you can do it, slowly increase activity. This doesn't mean running a marathon, but just walking around and making sure you aren't staying in bed the entire time. Frequent movement's important to prevent deep vein thrombosis, but additionally, you need to rest. You need to sleep when the baby sleeps, eat small frequent meals, and let people help you. Finally, do not give yourself secret rules. Like, my in-laws are coming over, I need to clean the entire house. But laundry always gets done on Tuesdays. The most important thing is that you take your time, move a little bit, but rest. So when can you exercise again? So generally, avoid anything other than upper body until 6 weeks afterwards. I really suggest getting checked with your doctor for your specific pregnancy. And pelvic rest for at least 6 weeks. Pelvic rest means nothing in the vagina, no intercourse, no menstrual cups, no tampons, no nothing. And avoid heavy lifting for the same reason. And when you do want to start exercise again, make sure you resume gradually, as you might have gotten rusty during your pregnancy. Special precautions. I'm sure you've probably heard this, but babies are very vulnerable to infections. Limit visitors. Before touching your baby, wash your hands for at least 20 seconds, or if you don't have soap and water, an alcohol-based hand sanitizer, and avoid leaving your house extraneously, which you've probably been doing because it's 2021.
So some takeaways from this talk. Again, we want to stress the importance of attending your postpartum visits and sharing all of your concerns and symptoms with your physician. As Isaac just stressed, rest, give yourself time to heal, set aside a few hours per day to relax if possible, try to sleep when your baby sleeps, and reach out. Talk to other parents, confide in people you trust. You are not alone. And especially during this time of COVID and the pandemic, consider joining support groups. There are a lot of virtual options right now. And these are our resources. I'll stop sharing so we can go to the Q&A session.
Thank you so much to our students. You really did a great job. Put my video back on so you can see my floating head over here. I can talk. So 2 questions came up in the chat, so I'll address those first, and then if anybody has any questions, you can feel free to raise your hand and we'll go from there. Can everyone hear me? I just want to make sure.
We can hear you.
Okay, good. So One of the questions was, will my doctor see me, will an OBGYN see me for my postpartum visit, or will it be the hospital? So typically when you stay in the hospital after a baby, for a vaginal delivery is typically 2-night stay if it's uncomplicated, and a C-section is typically 3-night stay if it's uncomplicated. Sometimes the baby has jaundice and they need to go under phototherapy. At Mountainside, we really have a great program, and we have maternal support rooms, so you can stay with your baby even if you're discharged for a day as a courtesy, which I think is a really nice touch that other hospitals don't offer. Also in COVID times, if we are really trying to get patients out sooner if they're safe. So a lot of the vaginal deliveries are getting discharged at day 1, and the C-sections are getting discharged at day 2. But again, we have to deem both ourselves and the pediatricians that it's safe for discharge. As far as the postpartum visit, you will go and follow up with your doctor. The recommendations now are to see your doctor multiple times in the postpartum period. The most critical time is in the first 6 weeks. So I see all of my patients at 1 or 2 weeks, depending on whether they had a C-section or a vaginal delivery. We screen them for postpartum depression, we do their vitals, and we check on their, see how things are going, see how they're feeling, how they're coping. And then at the 6-week visit is when we do the full exam and talk about the birth spacing and the birth control and diet, exercise, and everything. So definitely, don't be afraid to ask your doctor. Don't be afraid to speak up to your doctor about what's going on. And then if you aren't pregnant yet, or you've had a pregnancy in the future, please definitely try to get your family histories in order and think about what happened with your past pregnancies, or get your operative reports or your records in order and bring them to your new doctor so that they can really give you the best care, because things that have happened once are most likely to happen again. And it just helps us work with you more. So that at the postpartum visit, definitely speak up about what's going on. The other question that came up was, can I walk after 5 days after a C-section? Walk a lot. So it really depends. You should be moving after any delivery. When you're pregnant, you are at a greater risk of blood clots, which we will get into shortly. So I'm not going to get into that now. However, you have to ease into it. As Isaac said, you have to take your time and see how you feel. You can do little ankle rolls when you're in the hospital. You'll have the sequential compression devices on that help with blood circulation. And you should move about the room as much as possible, and increase as tolerated. It'll take about a week for you to start feeling a little bit like yourself again, particularly if you've had a C-section or if you had a vaginal delivery with a tough tear. But moving around is important, even if it's for 5 minutes or 10 minutes, and then you take your frequent breaks. And your doctors will go over your pain management plan. We really try not to give a lot of opioids, but if they're necessary, we'll give them in a safe manner, and you'll be monitored closely. So at 5 days, you should be up and walking with reason. No heavy lifting, no squatting, no lunging, no driving, but definitely moving around. I got a few more in the chat. Is there a current recommended time to wait before having visitors to see the baby at this time due to COVID? So there's not a hard and fast rule on this. With COVID times in the hospital, at least at our hospital, we're allowing 1 support person. The rules do change frequently, and it really depends on the numbers. When we were in the heat of everything back in March and April, people needed to stay in the hospital at all times. Partners were not allowed in for C-sections, and that's for the safety of the patients and for the staff. You need the staff there so that they can take care of the patients. But now partners are allowed to go in for C-sections again, and we really are managing wonderfully. Like, our staff is great. Everyone's wearing universal protections, eye protection, and PPE at all times, and really doing everything to keep you safe. All patients are getting tested upon admission, and partners are getting temperature check. We have exclusive mask policies. So for right now, babies are very fragile. They'll be seeing the pediatrician within the first week of life and multiple times. The first 2 months are very fragile before they get a lot of their vaccinations. So I do think you have to be very cautious, especially during this time. I am recommending that most of my patients, try to do virtual meetings and really not have any exposure. As more people, if they choose to get vaccinated for COVID or have the availability, that may change. But right now, I'm really telling them to try to steer clear. If you have very close family members that you trust, that they're social distancing, or you wish to get them tested ahead of time, I know myself, I get tested before I see my my little nieces and nephews. I had a nephew born in February of 2020. So, it was definitely a tough time there. And we just have to really work on protecting each other. As much as we want to see each other, it would be devastating to have somebody sick. So I think in general, taking the precautions, flu and COVID, are very important. There was a breastfeeding question that came up, so we'll talk about that in the breastfeeding section. Should you stop having intercourse before having your baby? No, that's not necessary, unless your doctor says otherwise. If you have a low-lying placenta, or you're having issues with bleeding, or you have an extremely high-risk pregnancy, you would be specifically told not to engage in intercourse. However, if you are having an uncomplicated pregnancy, your doctor actually may encourage it as you get closer, as it has been shown to help naturally stimulate labor by releasing what's called prostaglandins, and may help to move things along. So if you're up to it, I never tell people to, but I do say, if you're up to it, it may help move things along. So you should always do what's comfortable for you. For the sake of time, I think I'm going to take one more question, and we'll move on to the next. And then, what gears or extra tools to help are necessary for the recovery or healing? Really, I mean, when you're in the hospital, the whole point, the most critical time for you in the hospital is the first 24 hours. That's when you're at the greatest risk, and you'll be equipped by your doctors and our wonderful nursing staff to ask as many questions as you want. We'll talk about fever, pain, and bleeding precautions. So it's just really important to ask as many questions that you can. And then, as far as if you have any questions as far as the tools, I would just say, take it easy, listen to your body. There are a lot of compression stockings and support belts and a lot of things that can help you in the recovery period. Physical therapy is a very important thing to consider. A lot of women, because your body changes, the physiology of pregnancy, your body changes. It's important to consider that. But just really speak up and talk to your doctor, and I think they can guide you through all the tools in the postpartum process. If you have any specific questions about that or need some more resources, you can definitely email me, and I'll happily email you some more resources at the end of the talk. But I think for the sake of time, I think we need to move on to the next discussion. So we'll let the students pull up as far as maternal mortality right now, if that's okay.
All right, 1 second. I'm just going to share my screen. And if someone can give me a thumbs up that you can see it.
You're good, Karen.
Okay, perfect. All right, so hi everyone. My name is Karen, and Theodore Langlois is also going to present with me on maternal mortality. And this word, maternal mortality, might seem scary, but it's often very preventable. And we just want to review the info with you so that you can stay healthy during and after your pregnancy. And we're going to give you some warning signs to look out for so you can talk to your doctor about these things. All right, so first let's go over maternal mortality in the United States, and let's define it. So maternal mortality is a death that's due to a complication from pregnancy or aggravation of a pre-existing condition by pregnancy. And different review committees have different definitions for what maternal mortality is, some of which are on the slide. And direct deaths are those that are directly caused by pregnancy, and they can occur up to 42 days after pregnancy. There's also indirect deaths, and those are deaths that are associated with another disorder but are exacerbated by pregnancy. Late maternal mortality occurs up to 1 year after the end of pregnancy. And an astonishing 700 women die in the US due to maternal mortality annually. So this is why we wanted to bring this topic up and address it today. So let's take a look at a global perspective. So every day in 2017, 810 women have died from preventable causes that are related to pregnancy and childbirth. And in 2017, approximately 295,000 women have died during and following pregnancy and childbirth. And studies have found that the majority of these deaths occurred in low resource settings like sub-Saharan Africa and Southern Asia, and most could have been prevented. There are several causes of maternal mortality, and some of which include a venous thromboembolism, and that just means that there's a clot in your veins. Severe bleeding after delivery, infections can be a cause of maternal mortality. Pregnancy-induced hypertension, so you might have heard of the terms pre-eclampsia and eclampsia. Complications from delivery, unsafe abortion, cardiomyopathy, and comorbidities, which are diseases that are in addition to others. And we'll briefly touch on each of these topics one at a time. So first, let's tackle venous thromboembolism. So you might have heard a DVT or pulmonary embolism before, and those are just examples of venous thromboembolisms. It's the third most common cardiovascular disease. About 30% of patients with VTE experience another venous thromboembolism in 10 years. They are 4 to 5 times more common among pregnant women than women who aren't pregnant. And those are because of physiologic changes that occur in pregnancy. So some women, or most women who are pregnant, just have an increased number of clotting factors when they're pregnant. And also some pregnant women are more sedentary while they're pregnant because of the increased weight. So it's one of the leading causes of death in pregnancy in the United States. The risk has been found to be 1.5 times greater among Black patients than white patients, and the risk is lowest among Asian American patients. The risk becomes much higher in advanced maternal age, which is now defined as age 35 and up. So how can we prevent thromboembolisms? Well, know the signs, advocate for yourself. If you're feeling any shortness of breath or high heart rate, or you notice any swelling of the legs, definitely talk to your doctor. Try to maintain a healthy weight. You can also wear a pneumatic compression device, which kind of look like giant sleeves that you wear on your legs, and they help massage your legs and allow your blood flow to get going. Know your family history, because a lot of these conditions can be genetic. Start walking as soon as possible after a C-section. So we're addressing one of the questions that were on the chat. If you have any risk factors for clotting, definitely talk to your doctor about medications. All right, so the next cause of maternal mortality we'll tackle is the bleeding in postpartum period. There are both primary causes and secondary causes, and keep in mind some secondary causes are similar to primary causes. So some primary causes include uterine atony, and in other words, that means that after pushing or after having a baby via C-section, your uterus just becomes so exhausted that it's tired. And lacerations can be a primary cause. Retained placenta or abnormally adherent placenta. So sometimes the placenta is so strongly attached to the uterus that it's hard to remove, and that can cause bleeding. Coagulation defects, uterine inversion, and infection, as well as routine products of conception. Some secondary causes include an overly distended uterus. So if pregnant patients have extra fluid in their uterus, that can cause an overly distended uterus. multiple gestations. So if you have twins, or if your baby has macrosomia, which means it's a little bigger than usual, that can also cause an overly distended uterus. Uterine atony, as we spoke about briefly earlier, infection, as well as anatomic abnormalities. So how do we prevent bleeding in the postpartum period? Well, this one's on us. We make sure we administer medication that can help strengthen the uterus and keep it firm. And we also apply a uterine massage. Next, infections. So in 2014, it was found that infection affects 5 to 7% of postpartum women, with higher rates for women that undergo C-sections. The type of infections that can occur are surgical site infections. So women who had a C-section, they're more prone to these types. Endometritis, an infection of the uterus, can occur. Septic pelvic thrombophlebitis, which in other words just means infection of the pelvic veins. Mastitis, infection of the breasts. Urinary tract infections are common, and episiotomy infections. And an episiotomy is a surgical cut that is made during delivery to allow more room for the baby to come out. So that can also become infected. And the way that we can prevent and reduce the risk of infection, again, know the signs and symptoms to look out for. So if you notice fever, chills, or temperature greater than 100.4, definitely let your doctor know as soon as possible. We can prevent mastitis by treating breasts saturated with milk with early emptying. Keep any incisions and wounds clean. Avoid any vaginal douching. It can alter the normal pH of your vagina, and avoid shaving the area as it can increase risk for microabrasions and introduce new bacteria. What we as providers can do for you to reduce risk of infection is we give you antibiotics for prevention. Definitely before C-sections, we give antibiotic prophylaxis. We make sure we prepare your skin appropriately for both for C-section and vaginal deliveries. We limit the number of vaginal exams that we perform, and we make sure we adhere to sterile technique. And again, we ask you a million questions because we want to know your risk factors. So when we're aware of your risk factors, we can also reduce the risk of infection. Okay, so next we'll tackle high blood pressure. So you might have heard the word preeclampsia, and it's what it is it's a complication in pregnancy that's characterized by high blood pressure. And there's also signs of damage to other organs, such as the liver and kidney, and it affects up to 15% of pregnancies worldwide. So for prevention and risk reduction, make sure you have your blood pressure monitored before, during, and after pregnancy. Be aware of the symptoms of heart and blood pressure problems. Definitely consult a cardiologist before pregnancy and 3 months after if you have any heart problems or elevated blood pressure. Report if you experience any severe headache, any vision changes, shortness of breath, asthma, if you're not responsive to your usual medications, more difficulty while laying down flat, heart palpitations, chest pain, or increased swelling of the hands, feet, or face. There are many more ways that you can reduce your risk, and those include using little or no added salt, reduce processed foods when possible, drink about 6 to 8 glasses of water per day, avoid fried or junk food, get enough rest, exercise regularly, elevate your feet several times during the day, avoid any alcohol or caffeine, and your doctor may prescribe medicine or additional supplements or baby aspirin in order to further reduce your risk. And now I'm going to introduce Teddy, who is going to proceed with our presentation.
Hi, everyone. So I'm going to start off by talking about some complications from delivery. This is by no means an exhausted list. And like Karen said, nothing we're talking about today is to scare you. It's just to let you know some things that could go wrong so you can keep a watch out for them. Because if any of these things, for the vast majority of the things we mentioned, if they're caught early on and treated early on, they do have a good recovery. So we just want to give you all the tools to stay safe. So some complications that may arise from delivery is arrest of labor, which is when the labor may slow down or stop. So this may be when your contractions weaken or the cervix, i.e. the opening to your womb, doesn't dilate or expand wide enough, or the baby gets stuck when descending. And this can increase the risk of uterine atony and infection. And this may mean need to be managed with medications that could increase the rate of contractions and speed up labor, or this could mean having a C-section. So it's just important to talk to your doctor early on, especially if you had a problem with this in a previous pregnancy. Another problem could be a tear in the perineum, the area between the vagina and the anus. And this would just be repaired with stitches. And one thing to note is just that you need to keep this area clean and watch out for infections. And this is an area that's easier to get infections due to where it's located on the body. So proper hygiene is really important. Another problem could arise, such as abnormal fetal heart rate, and this might mean a C-section or repositioning you during delivery to get more blood flow to the baby, or your water breaking before you're ready for labor. And again, this would mean to be continuously monitored, and you would have a risk for infection or excessive bleeding. So if any of these things are happening, especially before you go to the hospital, you want to call your doctor as soon as possible and then follow up within a week after delivery for care with either your OBGYN or your PCP to make sure it doesn't cause any lasting problems. Okay, so now we're going to go on to the next slide. So unsafe pregnancy termination can result in about 5 to 13% of maternal deaths. And between 2015 and 2019, about 73.3 pregnancies ended up in induced pregnancy and termination. And an estimate from 2010 to 2014 shows that about 45% of abortions were unsafe. And most of these abortions that were unsafe took place in developing nations that had lower healthcare resources. So how do you distinguish between safe and unsafe pregnancies, abortions? So a safe abortion is one that's carried out in a proper manner and by someone that has the proper skills. So something that you would receive at Planned Parenthood or a doctor's office. An unsafe abortion would be one that's done at home or one that's done inappropriate for the time in the pregnancy. So what are some things that you can do to remain safe? First of all, know that it is always your right to change your mind about your pregnancy, and there is no shame in this. The main thing is that you get access to safe and proper health care. So please talk to your doctor early if this is something you're considering. There's never going to be any judgment from your care team, and if there is, that's something that we want to know about. Another thing is making sure that you and people in your community have access to comprehensive sex ed and effective contraception. And the final thing is a timely emergency treatment of complications. So a lot of people feel shame due to the stigma around abortion and don't get help when they need it. And so if this is something that you're experiencing after effects, please know you can talk to your OBGYN. Okay. Now, a big problem that this nation is facing is maternal mortality disparities. Black women face the greatest amount of disparities, and they face maternal mortality rates 3 times greater than that of white women, and those rates go up to 5 times greater for Black women over 30. And one of the biggest drivers in this is structural racism, both in society at large and in the medical profession. Native American women have maternal mortality rates about 2.5 times that of white women, and maternal health and mortality are understudied for women who have sex with women, such as lesbian and bi women, and for trans men. But these populations have a great number of preconception risk factors, like higher blood pressure, higher rates of heart disease, and the like. And as you can see, there's also higher rates of C-section and preterm delivery. So what are some ways that we can address the impact of racism on maternal mortality? Much of this is on us as healthcare providers to change. But some things that you can do to ensure that you remain safe is to share your concerns if comfortable with your care provider. This may be a hard conversation to start. And one way you can do it is to say something like, you know, I've heard that women who share my race, or women who are queer, or whatever demographic you may fall into, experience higher rates of maternal mortality. I'm concerned about this. What can we do together to make sure I stay safe? And some factors like heart disease and hypertension disproportionately affect people of color due to the effects of structural racism, food deserts, and the like. So, and about 57% of Black women struggle with hypertension compared to 37% of white women. And preeclampsia and heart disease are the leading causes of Black maternal death. So please make sure you make your regular OBGYN appointments. And if you suffer from heart disease, consult a cardiologist before pregnancy, if possible, or during the pregnancy. And also address any factors such as previous preterm deliveries, because Black women frequently experience preterm deliveries. And we also want you to feel comfortable talking to us about your mental health as well as your physical health. Because carrying this stress has a big impact on your mind and body. Additionally, Black women often get less pain management during C-sections and difficult pregnancies. So please know that you can talk to your care provider if you feel like your pain isn't being appropriately managed. And it's good to develop a list of birth preferences and create a postpartum pregnancy plan and share this with your care team early. And some tips overall to reduce maternal mortality. During pregnancy, you want to try to maintain a healthy weight. Like Isaac was saying earlier, we're not here to be the food police about eating healthy. Just do what you can and what you can afford, and talk to your team if getting safe and healthy food is an issue. Exercise to the amount that you're able. Abstain from alcohol, tobacco, and unprescribed drugs and medications, as these affect your health and the baby's. And if this is something that you've struggled with before, please talk to your care providers about this. There are people who can help you with making sure you stay in recovery, and there's no shame in struggling with addiction. Please attend your regular OBGYN visits. It's important to stay healthy. I know it's scary during COVID. And talk to your doctor about any pre-existing conditions you have, previous preterm deliveries, and any mental health issues you may be struggling with. And after pregnancy, some things that you can do to stay safe, if we can go to the next slide, Karen, are follow up within 7 to 10 days if you had heart disease, high blood pressure, other risk factors during pregnancy. And if the hospital allows you to, bring a support person with you into delivery and appointments, and see your OBGYN within 3 weeks of delivery for postpartum care, or 1 week if you experience any problems during delivery or pregnancy. Okay. And so this magnet is going to be in the folders that Dr. Parisi prepared for you, but the handy acronym of when to consult your care team after delivery is post-birth. So if you experience pain in your chest, difficulty breathing, seizures, or thoughts of hurting yourself or someone else, please call 911. And call your doctor if you're experiencing bleeding greater than 1 pad an hour, or blood clots greater than the size of an egg, an incision that's not healing, red or swollen legs, a temperature of greater than 104, or a headache that doesn't get better. Okay, and now we're going to turn it over to our guest physician to talk to you guys some more.
Oh God, of course. Should I just stay under him?
Yeah, probably.
You're muted, Dr. Parisi.
I'm talking to myself, sorry. So I want to introduce a very dear friend and colleague of mine, Dr. Daniela Montemiro. She's a board certified obstetrician and gynecologist. She received her medical degree from St. George's University. School of Medicine and completed her residency at St. Barnabas Medical Center in Livingston, New Jersey, where she served as the administrative chief resident. Upon graduation, she joined her father's longstanding practice in Cedar Grove, New Jersey, and both of them joined Mountainside Medical Group in 2019. Dr. Montemiro is a superb physician and wonderful teacher. She's kind, compassionate, and skilled in both deliveries and surgeries. So we're very lucky to have her here today to give us a little bit of insight on how she counsels her patients in the postpartum period as far as precautions to decrease maternal morbidity and mortality. And then I have a few questions that came up in the chat, so we'll address those after.
Hi, everyone. Am I unmuted?
Nope, you're good.
Okay. Sorry for the name, Christopher. Those are the side effects of homeschooling. That's my son's name. But thank you, Dr. Parisi, for the introduction. So I was asked to go over some of the things that I review with my patients in the postpartum period so that they're aware of things to look out for. And so when I walk into a patient's room after I've delivered their baby, and we're getting ready for that time to go home, I go over things with them that I think are important that they may not be aware of, but I as a physician would be concerned if they called me with. So the number one thing that I always review with them is their bleeding patterns, because many women don't realize how much the lochia and the bleeding that happens after a pregnancy is actually, they don't really know how to quantify how much is too much bleeding versus, too little bleeding. And so I always go over with them that, especially if they're breastfeeding, the number one thing they're going to experience is, every time they breastfeed, the same hormone that lets down the breast milk is the same hormone which is oxytocin, is what helps the uterus to contract and push out blood. So a lot of them are surprised by that cramping side effects that they get after breastfeeding. So I always go over with them that they will, notice that as they're breastfeeding, they will cramp, and that's the system is designed that way to make the uterus contract down well and go back down to size over the postpartum period, and that they will push out blood as they are breastfeeding. One of the things I tell them to watch out for is too much bleeding, is if they start to go through, about a pad every half hour. That's not a normal bleeding pattern. If they're finding that they're constantly running to the toilet with bleeding, I tell them that they need to let me know, because that's an abnormal bleeding pattern. Another thing that I go over with them is things that I would be worried about in terms of postpartum preeclampsia. I tell them to call me if they experience any headaches, any blurry visions, or just like a general sense of just not feeling like themselves, that they are to call me. If there's somebody that I'm worried about, postpartum preeclampsia, somebody that has had a history of high blood pressure or preeclampsia with the previous pregnancy, I will tell them to have a blood pressure cuff at home that they can monitor, and that they are to start to call me if they start to see elevated blood pressures in the range of 140s over 90s or higher, and to let me know. And that is the number one reason that most of my patients, almost all of them, I tell them I want to see them in that 2-week postpartum period to look for elevations in blood pressures and things like that, as opposed to the traditional 6-week postpartum visit that we originally used to do years ago. Because if you see a patient in that 2-week postpartum period, you're going to pick up on things that may not be going well for them. The number one thing I think I need to always address with my patients is postpartum depression. And the reason this is so important is because a lot of times when patients are experiencing depressive symptoms, they don't know who to talk to about it. There's an overwhelming sense of guilt or feeling like I'm failing, like as a mother, that why am I not bonding with my baby? Why am I not feeling right? Especially because family members and those around them are so elated over this baby's birth and are so excited, but they're not going through the hormonal shifts that mom may be going through. So for her, she feels very isolated to vocalize that she's feeling those feelings. So I always tell the patient and her partner that's present in the room on that discharge day, if you are feeling, the difference between postpartum depression and postpartum blues is that postpartum blues is feeling sad about something, but then maybe a half hour later you're laughing and you can feel happy again. Postpartum depression is this general feeling of guilt, not feeling like you're bonding with the baby, wanting to isolate from others, not feeling like you can get up and do those daily activities for yourself or the baby, feeling you just want to lay in bed all day, that's teetering over into postpartum depression. And it's important to let your doctor know that, because a lot of times the way I describe it to patients and their partners is that I want to catch you before you're heading over the edge of the cliff with that, with those feelings, as opposed to having to pull you up the edge of the cliff, because those medications that can help you take 2 weeks to kick in. So I don't want you to be so far gone in those feelings before I can help you. And that's also why it's so important to see those patients 2 weeks postpartum, because a lot of times they'll come in and I will say to them, how are you feeling? Are you adjusting well to motherhood? And if it's that mom that's struggling, I can immediately see the tears will come to her eyes. She'll start to say, you know what, Dr. Montamiro, I'm not feeling well. And that's how I can pick that up. And I always tell the partners, if you notice something, if you notice that she's feeling different, let me know, because a lot of times they don't want to admit it to themselves, and they feel like it's like they're, again, that feeling of failing. And so I've had many times where a partner will call me and say, she's just not right. And I'll say, okay, let's get her in. If it's a weekend, I get on the phone with the patient, I talk them through it, I call the medication in, but I'm going to want to see that patient, immediately in that week. And then I go over with them, it's important to make sure that they're supported, because, the most important thing is to ask is, are they going to feel they're going to hurt themselves or hurt the baby or hurt someone else? Because you never know who's that mom that's truly struggling and just doesn't want to admit it to themselves. So that's about the main things I go over. And I think also the other thing I go over in the postpartum period is the struggle around breastfeeding. Everyone thinks that breastfeeding should come naturally and easy. I always tell my patients it was one of the hardest things I ever went through with my own children. I found it harder than residency. And they laugh when I say that, but it truly is a struggle, because it's such a, if you're not that person that produces a lot of milk, it's a lot of like trying to get that milk there, trying to figure out a baby. I tell patients, my husband and I are both physicians, and we both struggled in those first couple of weeks with a baby. Like, what do we do with this baby? Because they cry, you don't know what they want. So I advise them to reach out to their pediatricians, reach out to their obstetricians, because that's what we're here for. It's not that care doesn't end the minute that baby comes out. We're here for them to help them struggle in those coping mechanisms, in the postpartum period. So I don't know if you want to turn it over to questions now. I don't want to take up too much time.
So one of the participants asked, what are the complications related to patients with hypotension during and after the delivery? So hypotension is low blood pressure.
What are the complications related to that?
Patients with hypotension.
Okay.
During and after delivery.
Okay. So usually when somebody's having low blood pressure after delivery, sometimes it can be the effects of just, everything they've gone through. People don't realize even in a vaginal delivery, you do lose a lot of blood, just because that uterus has been supporting that pregnancy for so long, and the blood supply to the uterus is so big and engorged that when a baby comes out, the uterus is a muscle. And so sometimes it clamps down very nicely and the bleeding stops, and sometimes it doesn't. The most important thing to make sure when you have somebody with low blood pressure is it a response where they're just tired and they're laying flat on a bed, or is it something that's more concerning? So you're going to look at that patient's bleeding patterns. You're going to look to see, is the heart rate elevated? Because if the heart rate is elevated above 100 or higher, then there might be a physiologic systemic response that's happening to that low blood pressure, and you need to look for, is the patient losing too much blood? If the patient's not bleeding, then you're more thinking, okay, it could be epidural related, mom can be exhausted. So those are the main things we want to look at. If the mom is a C-section, you're looking, how is her urine output? Because she'll often have a Foley catheter, which is a catheter that drains the bladder in the post-op period from a C-section. And you're going to look to see, is the urine output good? If the urine output is good, then mom is considered, stable, as long as her heart rate looks good and her bleeding patterns look good. So the number one thing you want to make sure of in the postpartum period, for particularly a mom who's lost too much blood and low blood pressure, is how does that affect, her pituitary gland, which is a gland in our brain that helps control our whole endocrine system. And so somebody who, had something like that can develop something called Sheehan syndrome, where they can get like a low output of their whole endocrine system. And that's a whole workup that we look up for in the postpartum period if mom is coming in with issues postpartum.
Great, thank you. Another question that came about, does having an epidural have negative consequences after birth?
Negative consequences, I think, related to the epidural are mainly depending on how difficult the epidural was to put in. You know, I had someone, a good example, last week, I had somebody who was a vaginal delivery that prior to putting the epidural, she's had this issue of her lumbar spine being very difficult to access in previous times when she had to have a lumbar puncture. So she kind of went in knowing she had this difficult spine, but our anesthesiologists were great at, you know, working at it, and they were able to get it in for her, even though it took several attempts. But somebody like her runs the risk of what's called a spinal headache, right? So a spinal headache is somebody that maybe had a difficult epidural that was difficult to place and had some excessive attempts. They might develop what's called a spinal headache afterwards, that then they might need caffeine or what's called a blood patch to help replace the volume lost in the epidural space to help relieve this headache that they get that is only relieved by laying flat down. So somebody like that would be a complication, or back pain that they can experience. But usually it's related to somebody who's had a difficult epidural. I find that my patients that have an epidural that was uncomplicated usually don't, have those complications afterwards. I myself, having had an epidural, I noticed mild tenderness in my back for about a week or so, but nothing that was out of the ordinary.
Thank you. So a spinal headache, the risk is about 1 in 100. So 1% of 100 will get a spinal headache. And like Dr. Montemiro said, sometimes it's as easy as some caffeine and hydration. And then other times you do have another procedure because that spinal fluid is leaking. So they put a blood to patch over that area. But it generally, it's epidurals and spinals are very, very safe procedures. And our anesthesiologists are equipped to do them on patients while you're contracting. They know how to reposition you and do it in between contractions. So you should rest assured that it's a very, very safe procedure. There is another question that came up that's not related to maternal mortality, but I think it is important to talk about. And I ran out of time with the postpartum visit. Can you just comment, Dr. Montemiro, on how you're counseling your patients on the COVID-19 vaccine right now?
So the COVID-19 vaccine, the way I've been explaining it to my patients is that obviously with the unprecedented time frame that this vaccine came out to help, overall humanity and, the immune response so that we could fight this virus. Obviously pregnant women weren't tested in the trials. So there's not a whole lot of data to really counsel people on what the effect of the vaccine would be on pregnant women or lactating women. However, being that this is an inactivated version of the virus, just like any other vaccine that's inactivated, such as the flu, theoretically, it should be the same safety profile for pregnant women and lactating women as those vaccines. So the way I explain it to patients is that it's a very personal decision, because obviously we can't provide you raw data because pregnant women have not subjected themselves to the vaccine and future, implications. But that being said, in pregnancy, you are in probably for a woman who has no prior medical problems in her lifetime, this is probably the most immunocompromised you're ever going to be in pregnancy. So I would worry more about COVID-19 affecting my pregnancy than I would more so than the actual vaccine. So the way I tell my patients is a lot of my pregnant patients that are nurses and doctors right now are opting to get it because they've seen the direct effects of this virus and the mortality it has impacted patients with. So they're opting to get it, and I probably myself would get it, but it's a very personal decision, so I kind of leave it to their discretion. I know a lot of patients are concerned about future fertility. I get patients asking me that all the time. The American Society for Reproductive Medicine put out a statement saying that they do not feel that it affects future fertility, and that they would not advise against getting it because of that purposes, especially because with the COVID-19 outbreak, we did not see an increased rate of miscarriage in the general population. So that miscarriage rate has not changed with COVID-19 being out there as a pandemic. So we shouldn't see the same effects in an inactivated version of the virus. So they feel strongly in stating that women should not preclude themselves from getting the vaccine because they're afraid of future fertility.
Thank you, Dr. Montemiro. I totally agree with everything you said. I know I gave everyone prior to coming on the call an introduction to American College of OBGYNs, and they give us advisories, and typically every week we're getting a new advisory, and it really is an individualized decision between you and your provider. And definitely if you're at home and your partner's at home and you're not exposed, that may be a different decision versus someone who is out in the healthcare field or is a first responder or an essential worker. So definitely encourage that conversation with your provider. I do think that, I do know that as far as women who do receive the vaccine within 30 days of becoming pregnant or while they are pregnant, they are to be enrolled in the SAFE-V Alliance, which is a study to get us that data so that we can further counsel you and get those numbers, because everything with COVID has been very new. And as a provider and someone who's a fixer, it was a very scary time. It's been a very scary time because we're kind of figuring things out along the way. And as I was telling you before, we thrive on evidence-based guidelines. So we actually are formulating the evidence now. So if you are on this call and you're not pregnant yet, you definitely should consider getting the vaccine. If you want to be a purist, you can wait a month before trying to get pregnant, but that again should be discussed with your doctor. But it should not delay you from getting the vaccine if you're interested in becoming pregnant. That's the last of our questions. So I think I really would like to thank you, Dr. Montemiro, for joining us. And I hope I know that has to be helpful information. If you have any further questions, you can keep sending them to me in the chat, or we can email afterwards. We will, Dr. Montemiro's information will also get shared with the folders, and we'll take a quick 5-minute break before we move on to our next topic.
Thank you.
On perinatal mood disorders.
All right, so my name is Katie Cushman, and I'll be discussing perinatal mood disorders with my colleague Fatima. So to start, it's important to note that experiencing emotional changes after childbirth is normal, but it's also important to recognize severe changes. So approximately 400,000 women suffer from perinatal mood disorders annually, yet it's believed as few as 15% get adequate assessment and treatment. And this can be for a variety of reasons, such as patients being afraid to speak out due to stigma, feeling like their symptoms are not important, timely access to behavioral services or behavioral health services, different cultural beliefs and backgrounds, as well as pressure from their partners and families. Women are often told that this should be the happiest time in their life, yet that might not be the reality for many women. The categories that we'll discuss today are peripartum blues or baby blues, peripartum anxiety, postpartum depression, postpartum psychosis, and then we'll also discuss a partner's experience with postpartum depression, as well as provide resources for individuals experiencing postpartum depression. So to start, we'll discuss peripartum blues. So what is peripartum blues? This can occur within days after childbirth, and this is where women begin to feel depressed, anxious, and upset. And it's extremely common and reported in more than 80% of women after delivery. The timeline and symptoms. So symptoms will usually start with peripartum blues within a few days after childbirth and then peak around 2 to 5 days. They will resolve on their own within 2 weeks after childbirth. Some of the symptoms of peripartum blues include sadness, tearfulness, fatigue, irritability, anxiety, confusion, feeling overwhelmed, increased sensitivity, mood swings, trouble sleeping, and appetite changes. However, this should not affect the mother's ability to function and care for her baby. And peripartum blues is not associated with feelings of worthlessness, helplessness, severe OCD, or suicidality. For treatment for peripartum blues is supportive care and reassurance. Medical treatment is not necessary. However, please still talk to your provider about your symptoms, and they will be able to counsel and support you during this time. And again, peripartum blues will usually get better within a few days with, or up to 2 weeks without medical treatment. So next we'll discuss postpartum depression, which is different from peripartum blues. And postpartum depression is associated with intense feelings of sadness, anxiety, or despair that prevent one from being able to do activities of daily living. And this can occur anytime up to 1 year after having a baby, but it most commonly starts 1 to 3 weeks following childbirth. And it's not completely understood how or why this happens, but please know that it is a physiological process, and it's not your fault. After childbirth, the body experiences significant hormonal changes, and this includes a dramatic drop in estrogen and progesterone. In addition, new mothers may feel sleep deprived, overwhelmed, anxious about their ability to care for a newborn, struggle with their sense of identity, or feel a loss of control. And all of these factors can contribute to the onset of postpartum depression. And again, it is fairly common and reported in 6.5 to 20% of women after delivery. Risk factors. So some women may be more at risk for postpartum depression than others. And so it's important to know the risks and be able to talk about them with your provider. So you might be at an increased risk if you have a personal or family history of mood or anxiety disorders. You have children at a younger age. You may be experiencing sociological factors. And so this can include stressful life events, having a low income, living in abuse, or being a single parent. Or if you have a premature or low weight birth weight infant, or have an infant with medical complications. Or if you've experienced pregnancy complications, have difficulty with breastfeeding, feel isolated or have a lack of a support system, or maybe having a challenging baby who cries more than usual, is difficult to comfort, or has irregular hunger and sleep patterns. Symptoms of postpartum depression can vary, and it's important to know that they can range from being mild to severe. And these symptoms can include, but are definitely not limited to the following: depressed mood or severe mood swings, excessive crying, difficulty bonding with your baby, withdrawing from family and friends, overwhelming fatigue or loss of energy, fear that you're not a good mother, hopelessness, feelings of worthlessness, shame, guilt, or inadequacy, severe anxiety and panic attacks, thought of harming yourself or your baby, recurrent thoughts of suicide or death, or physical symptoms. When to seek help. You should definitely call your healthcare provider as soon as possible if your symptoms do not improve after 2 weeks, if your symptoms are getting worse, or if your symptoms interfere with your ability to care for your baby or complete everyday activities. It's important that you schedule an appointment as soon as possible and do not wait until your scheduled postpartum visits. And then after discussing your symptoms with your healthcare provider, they can help you determine if you do in fact have postpartum depression and help manage and treat your symptoms. And also, if at any point you have thoughts of harming yourself or your baby, please seek help immediately and call 911. With prevention and intervention, so screening for postpartum depression is recommended at confirmation of pregnancy visit, or even consider screening during your preconception visit. And then screening is repeated throughout pregnancy and the postpartum period. And screening can also occur at the 2-month well child visit. And then again, please discuss with your healthcare provider any risk for developing postpartum depression. And then if you are deemed at higher risk, you may have additional screening or preventative therapy may be considered, and this can include counseling or medication. Treatment for postpartum depressions. Early treatment is important because it can help manage symptoms and help you bond with your baby. The current treatment includes therapy and medications called antidepressants. And then for additional help, Postpartum Support International does have online virtual resources, including support groups and a helpline.
All right, so I'll be taking over now. My name is Fatima, and I'll be going over the second half of this presentation. So this slide is basically just an overview of what Katie talked about before, with the main differences between peripartum blues and postpartum depression. So there are two different things. So with peripartum blues, in general, symptoms will go away on their own within 2 weeks, and the symptoms shouldn't be too severe to interfere with the mother's ability to function or care for her infant. And like mentioned before, the treatment is just supportive care and emotional support from the provider and the mother's loved ones. And postpartum depression is different than peripartum blues in that the symptoms persist for a longer time, so longer than 2 weeks, and the mother may have severe enough symptoms that will interfere with her ability to function and they care for the infant. And the treatment for this needs to be managed by a healthcare provider, and the treatment can range from, and it's important to mention that the treatment should be individualized. So some women may benefit more from medication, some may prefer therapy, and for some it may be just lifestyle modifications. And we wanted to very briefly talk about peripartum anxiety because it can be a little bit hard to distinguish between any normal or appropriate anxiety in a given situation from something that requires further attention and or treatment. And it's been actually known that 1 in 5 pregnant women are known to suffer from at least one type of anxiety disorder. So the symptoms can range from panic attacks, excessive worry, restless sleep, hyperventilation, and just constant negative thoughts that, oh, something bad might happen to my baby or something bad might happen to myself. So the treatment for this, it really, a lot of it, most of it really does overlap with postpartum depression. So it includes emotional support, medications, and therapy, and again, treatment is individualized. And the next mental disorder that we wanted to touch upon was postpartum psychosis. So this is actually much more rare than peripartum blues and postpartum depression and peripartum anxiety. So it's reported to occur in about 1 to 2 births per 1,000 births, and this is defined as acute onset of manic or depressive psychosis within the first days or weeks after delivery, usually happening within the first month. And the risk factors for this include having another psychiatric conditions such as bipolar disorder, schizophrenia, and if you've had postpartum psychosis with a prior pregnancy, or if you've had a first degree relative suffering with postpartum psychosis. And on the next slide, I'll go over what psychosis really means, like what the definition and symptoms of that are. So early warning signs may include the mother isn't able to sleep for several nights, or she's avoiding the infant. So psychosis really means having hallucinations, so they can be auditory or visual. So you're seeing something that isn't actually there, or you're hearing something that isn't actually there. Uh, a mother can have delusionary thoughts, just very disorganized thoughts, kind of like what they say, like, oh, they can hear voices in their head, behavior that is very unusual from the mother's normal behavior, being agitated very easily. And this is a psychiatric emergency with the risk of infanticide and suicide if not treated immediately. So it does require immediate intervention. So it does consist of inpatient treatment with therapy and medication, and temporary separation of mother and child may be necessary for safety measures. So what you can do now to prepare, build your postpartum care team. So your postpartum care team can include your family and friends that you know for sure you can rely on um, if you ever feel any of the symptoms that we described before with the mood disorders. It can include your OB-GYN provider. So this is good so that you will know who to call if you think you may have postpartum depression or any of the other mood disorders. And during your appointments, do make sure to talk to your healthcare provider about any risk factors that you may have. And remember, the most important reminder is that you are important and that your needs to sleep, eat, and bond with your baby um, are really important. So you have to take care of yourself in order to take care of your baby. And we also really wanted to touch upon how partners can support a mother going through postpartum depression, and also about spouses having postpartum depression themselves. So, helping your partner suffering with postpartum depression, the most important thing is just to listen closely, validate their emotion, and just constant reassurance that postpartum depression isn't their fault and the treatment does work. It is due to just the hormonal changes that happen after giving birth, and so just helping the partner understand that what they are experiencing is temporary. Do make sure to give your partner some me time. So if they just want to be alone and then relax on their own, that'll help them get a hold of what they're feeling, and just help them relax and help around the house so your partner can rest. And new fathers can also experience postpartum depression. So an estimated 4% of fathers experience depression in the first year after their child's birth. So, risk factors for this include fathers that are young, fathers with prior history of depression or any other mental health disorder, fathers facing financial difficulties, or the mother having postpartum depression. So, it is very important to realize all signs and symptoms um, and know that treatment options do include psychotherapy, antidepressants, seeking out social support from loved ones, and these can also be talked about with the healthcare provider because, like emphasized before, individualized treatment is the goal. So, key takeaways from all of the disorders that we mentioned. So, experiencing temporary emotional changes is common and normal for the first few days to weeks after childbirth. And if you ever have the gut feeling that something just doesn't feel right, or something is interfering with your daily activities, then do not wait to seek help. Seek help if your symptoms are lasting beyond 2 weeks. So, postpartum depression, although it is serious, it is treatable and it is managed well. And you just have to remember to take care of yourself as well. Your needs are important. And postpartum psychosis, that we just talked about, is a serious mental illness in which patients have delusions and hallucinations, and treatment should be sought out immediately. And like mentioned before, there are many ways that partners can help new mothers suffering with postpartum depression. So over here, we just wanted to talk about the resources that are available for new mothers and partners who may be suffering from postpartum depression. So there's a PSI helpline that's available in English and Spanish. So patients can call this number to talk about anything. Mountainside Medical Center does have their own 24/7 crisis hotline that you can call. And any emergency, if you ever feel um, like you have thoughts of harming someone or harming yourself, the best thing that you should do is call 911. And there are weekly online PSI support meetings as well. If you guys go on the link over there, there's a PSI directory that can help you find a healthcare provider who may be experienced in treating postpartum depression. And the state of New Jersey Department of Health has their own family health line that you can use 24/7. So over here we have trained counselors that are available to provide information and referrals for health screening and treatment, including postpartum depression. And they do have interpreter services available as well. So these are the references that we use to get our information. So the slides will be provided after. So if there's anything you missed or you want more information on, you can go on to these links over here. And now I believe we have a clinical psychologist, Dr. Alexis, coming to speak with us for a bit.
Thank you both. You did an excellent job. Postpartum depression and perinatal mood disorders are very serious and important topics to discuss. And the one takeaway that I would really suggest is please be open with your providers. Let them know how you're feeling at all times. We're here for you. The motto of the New Jersey State Hotline is speak up when you're feeling down. So sometimes we can't tell, or your family members can't tell. It is a time where, like Dr. Montemiro said early, where you're expected to be elated. This is the happiest time of your life, but sometimes it doesn't feel that way. So know that this is a temporary situation. It is a physiologic change in your body. You cannot help it, but we can help you and we can treat it. About 400,000 women a year suffer from some perinatal mood disorders, so you are not alone. And definitely at your well visits or your preconception care visits, which I encourage all of you to make if you're not pregnant already and are interested in becoming pregnant, you should consider that within 1 to 3 months of your pregnancy. And you should really talk to your doctors if you've ever suffered from anxiety or depression, if you've ever been on any medications, because the recommendation is to continue your medications while you are pregnant. We may have to alter some of the medications depending on if they do have any side effects in pregnancy, but there have been some medications, particularly the SSRIs, like Zoloft is an example of that, that have been very well studied in pregnancy, and the recommendation is to stay on them because, like Katie and Fatima said, you really need to be well to be able to take care of yourself and to be taking care of your baby. So please speak up. We are always here for you, and partners as well. If you notice something is quote unquote off, just give your doctor or your wife, your partner's doctor a heads up. So without further ado, I am going to introduce our next speaker, who we were very, very fortunate to have. The creator of Conscious Motherhood Experience, Dr. Alexis Menken, is a clinical psychologist with more than 25 years of experience focusing on reproductive mental health. She is on the Advisory Council for Postpartum Support International, PSI, as we mentioned, and she has been a New Jersey coordinator for almost 20 years. She's the co-founder and current co-president of the PSI New Jersey chapter. She has served on Governor Cody's task force for postpartum depression. She sits on the New Jersey Maternal Mortality Review Committee and is on the board for the Partnership for Maternal and Child Health. Dr. Menken is a co-author of Perinatal and Postpartum Mood Disorders, Perspectives and Treatment Guide for the Healthcare Practitioner. And she is in private practice in Montclair. She's available to see patients via telehealth in both New Jersey and New York. So we are so very lucky and fortunate to have you, Dr. Menken, and we'll turn it over to you so you can give us your thoughts. And then we have a few questions in the chat, so I'll address them when you're finished.
Thank you for including me. I'm going to speak a little bit about Postpartum Support International today and give you some of the history, but I just wanted to thank Katie and Fatima. I thought that was a wonderful overview. And also, I really appreciate your highlighting anxiety, because I think we talk a lot about postpartum depression, and that's what people hear about in the news. So when women are having anxious thoughts, like they need to go in and check and see if the baby's sleeping all night, they don't think that's postpartum a postpartum mood disorder. So I think we need to expand our thinking and think of things. There's an expression called PMADS. I don't know if you've all heard of that, but that's perinatal mood and anxiety disorders. And really, I think we should start trying to refer to this as PMADS and not postpartum depression so much, so people recognize that those anxious thoughts really can become a mood disorder. And to your point, Fatima, you illustrated the question of whether or not it's just normal anxiety or it's a mood disorder is really a matter of duration and severity, which we figure out over time. But, you know, always reach out and ask for help. So I'll tell you a little bit now about PSI, which I'm glad to hear you guys, you're giving our resources out and you know about. So a quick history, Postpartum Support International, which is known as PSI, was founded in 1987 by a woman named Jane Honickman in Santa Barbara. And she founded PSI after experiencing the isolation and stress of new motherhood herself, realizing there were no social supports at that time for the transition to parenthood. She set about to change that, and she started going to scientific conferences to promote social support and reached out to civic organizations to develop social support advocates. When she started PSI, it was just Jane and her phone connecting parents and providers around the world. Her children grew up learning to answer their home phone saying, "Hello, Postpartum Support International." So we fast forward to today, where we now have a paid executive staff, more than 400 volunteers, 12 virtual support groups every week, and 40 chapters across the nation. We answer about 1,000 helpline calls per month. We've also trained thousands of providers. I've been the PSI New Jersey volunteer coordinator, as Dr. Parisi mentioned, for over 20 years. And I founded, and I'm the current co-president of the New Jersey chapter. I encourage you all to look at the website. We're actually developing a new website now, so it will be available soon, but look at postpartum.net. It's self-help and for providers. So it's an interesting organization. And if you ever have a chance to go to the annual conference, we have kind of two tracks. One is the moms who have been through something who come and want to learn more and maybe give back in some way. And then there's the professional track. So this is an organization that really serves both populations. So I encourage you all to, both professional and parents, to look at the website. And also we serve dads now as well. So any questions I'm happy to field.
Great. So first question, can medication that you were taking prior to getting pregnant increase your odds of getting postpartum depression?
I guess the question would really be, does a history of a prior mood disorder put you at risk? And the answer to that is yes. It's not linear. It doesn't mean if you've had a depression in the past that you will have a postpartum mood disorder, but it's a risk factor. So certainly if you've been on a medication, talk about it with your provider and don't necessarily assume you should just go off it when you get pregnant.
Absolutely. Like I said before, there are several medications that are safe in pregnancy. And some patients are like, I stopped as soon as I found out that I was pregnant. And a lot of the medications you cannot abruptly stop because you can have withdrawal symptoms from them. And again, they are recommended to stay on. So that's why the preconception counseling visit or the annual visit is so important. Or as soon as you get that positive pregnancy test, give your doctor a call and say, listen, this is what I'm taking. Should I stop or should I switch to something else? And speak to your therapist, speak to your behavioral health specialist and providers, and they are all well versed in this as well, and we're here to support you. There's another question.
Before you go there, I loved your recommendation to do the preconception counseling for mood disorder and also during pregnancy. When I worked on Governor Cody's task force and we came up with the screening at birth, it really is just like a one moment in time, and who's not crying at that time, right? All of us, I think. So also moving forward, and I'd love to get pediatricians involved. A mom sees a pediatrician more than any other physician in her first year postpartum. And if we could somehow get the screening involved there, that would be great. But I love, you're already doing the front end, which is wonderful.
Absolutely. When you are all in the hospital after you give birth, you will be screened. There's a scale that we use. It's a 10 10 questions that you'll be asked to answer, and you should really answer them honestly. And then in my practice, I screen all my patients at that 1st to 2nd week visit that I was mentioning during my postpartum talk, and then again at 6 weeks. And then if any patients come in within the 1st year with signs or symptoms of perinatal mood disorders, we screen them again. So it's not that you can only be screened once or twice. It's a really helpful assessment tool, and you should always answer it honestly, because it kind of guides us in how we should address things. Postpartum or peripartum blues are very, very common. And even though they are self-limited, it doesn't mean you can't reach out to your doctor if you need some support. 80%, up to 80% of women can experience some level of that. And just feeling overwhelmed, particularly if it's your first child. And then right now, what I've noticed with my patients, especially during a pandemic where we're all isolated and you may not have that support that you normally have, you may be a lot more prone to postpartum anxiety or postpartum depression. So it's really very important to speak out on that. The next question, I'm normally a very anxious person. I get anxious over everything. So after delivery, how will I know if my anxiety is due to a mood disorder or if it's just my natural instinct?
It's a great question. And again, I'd go back to duration and severity, your ability to function, to sleep, to take care of your baby. But we all bring who we are to the table when we become mothers. And so that might be something that's pre-existing for you that you'll work with in your new role as a mother.
And we just touched on this a little bit as far as COVID. Can COVID anxiety and isolation contribute to perinatal mood disorders, and what can we do to minimize this risk?
Such a good question. And I think we're learning this in real time. And part of the, we know postpartum mood disorders are, for some people, partly hormonal, partly social. Every aspect of your identity gets kind of thrown up in the air, and we see how everybody kind of settles to integrate those things differently. But one of the goals of Postpartum Support International is to recognize how valuable social support is. And during COVID, it's just been extraordinary to watch all of my, young families and patients struggling to do all this on their own in isolation. And it's a problem. And I think, trying to reach out in any way that you can, if you can pod with another family safely, using Zoom, I think, people are being tested in ways that we never could have predicted.
Right. Definitely stay in contact with your family members, your friends, your support staff, even if it's virtual. I always tell my patients also, sometimes they need me to give them a little permission to, step away from the baby for 15 or 20 minutes at a time. Go take that warm shower, hot bath, go, remember what your hobbies were, because especially as the baby does grow a little bit, you can step away and take that time to exercise or to do something positive for self-care, because it really will have you refocused and re-energized to come back and even be a better mother. So you do not, obviously the baby needs 24/7 supervision, but it doesn't always have to be you. It can be your partner, or if you do have a safe person who's doing safe social distancing, or who was tested, who you trust in the early postpartum period, that's possible. We are not machines. We are not meant to, even as an obstetrician who doesn't sleep very much, I know that what I get like when I'm up for days at a time. So you need time to sleep, you need time for self-care, and cut yourself a break a little bit, okay? So the last question we have is, can stopping breastfeeding bring upon postpartum disorders due to the hormonal shifts? We also, I'd like Dr. Menken to comment on that if you have any comments. And then we have our next speaker who is a lactation specialist. If she has any comments afterwards, I would welcome that as well.
I think that like all of these things, it's very individual, and I've seen women abruptly wean, and it looks like that brings on a postpartum mood disorder. And I've also seen women weaning slowly, where with each feeding that they give up, there's a little bit of agitation for a day or two. So I always encourage very slow weaning if it's possible. And the lactation consultant can probably speak to this more, but I think that it looks to me a little more like a premenstrual dysphoric disorder if someone weans abruptly, there's like an agitated, irritable quality that can come with that. And it passes with time, but why put yourself through that if you don't have to?
Lori, do you have, I can introduce Lori ahead of time. So Lori Barbelinardo is a registered nurse with over 40 years of experience in mother-baby services, with nearly 30 of them here at Mountainside Medical Center. She graduated from the Rhode Island College of Nursing, and she's a certified professional childbirth educator and has been teaching for the past 35 years. She has become an internationally board certified lactation consultant. That was in 1995. And she co-founded the very successful lactation support program at Mountainside in 1998 with Tish Buglin. And as I said in my introduction, the lactation program at Mountainside is incomparable. I have never seen a program so good. And I've worked at several regional hospitals. The lactation consultants really give great support to our breastfeeding mothers and before and after the delivery. Lori, do you have any comments on can stopping breastfeeding bring upon postpartum disorders from hormonal shifts? You're muted.
Can you hear me now?
Yep.
Okay. Well, thank you for the kudos about the program. We have worked hard with it. And as you know, from knowing us, it's a passion. I have actually read conflicting information, some saying that breastfeeding does not exacerbate any mood disorders. And in other circumstances, maybe the hormones of breastfeeding, it's really very individual. And I think, as Dr. Parisi said before, you have to just stay really in close contact with not only your OB, but any therapist or psychologist or anybody that you have been seeing. And I do think that people who have a pre-existing depression or anxiety disorder, obviously it is exacerbated by sleep deprivation and the hormones of delivery. So I think it's a conversation that has to be had in a really individual way. I do agree that gradual weaning for so many reasons is the way to go if you can do that. But yeah, the information is really kind of conflicting because it really is highly individual.
Yeah. Like all the things with hormonal changes, right? Why do some women, when the estrogen drops, have a mood reaction and some don't?
Exactly.
Yeah.
Exactly.
I've even had some colleagues and patients endorse a dysphoria with milk letdown. Mm-hmm. And I looked into that a little bit too, which I found very interesting and difficult to address because patients are so focused on breastfeeding and want to give their baby everything they can, which we'll get into the breastfeeding talk next, but endorsing this feeling of pure dysphoria and sadness when their milk lets down. And I had never even heard of that until about a year ago when one of my patients and a colleague of mine who mentioned that. I mean, there is one more question. Is there any natural treatment or exercise to reduce potential postpartum or peripartum disorders?
I can just say, I don't know about natural treatments. There are psychiatrists who try to work in less traditional ways. And I'm happy to post my email if anyone wants to reach out and I can refer you. But I think exercise is magic. And there's a great study that shows 30 minutes of aerobics 3 times a week is equivalent to SSRIs for major depressive disorder and generalized anxiety disorder when you follow women at 3 months, 6 months, and a year. And obviously the side effects are better. 30 minutes isn't a lot, but when you're postpartum, obviously you have to wait till you get clearance from your doctor. But I think the magic of exercise is not to be underestimated.
I think also there are some yoga, like 10-minute yoga programs that people can incorporate into their routine. 10 minutes, and anybody can find 10 minutes or have somebody watch their baby for 10 minutes. Mm-hmm. And I think yoga, especially when there's a little bit of meditation in it, is a really calming thing.
Yeah, and breathing, the breathing exercises that that's a great recommendation.
Right.
There are a lot of apps now and a lot of organizations who are offering, I know Headspace was offering to provide healthcare workers. They offered a free membership, and some of even, I'm not endorsing any of these programs, but I know Peloton, they have an app that they have like 10-minute exercise videos, and YouTube has videos, and there's a lot of ways with the computer and technology now in COVID times that programs are stepping up, and you can access them easily from the comfort of your own home. And same thing, we are in, our behavioral health colleagues are doing an amazing job. They are really inundated. I've never given out more therapy referrals for pregnant and non-pregnant patients right now. And we appreciate everything you all are doing for us and our patients. But it is convenient that a lot of the telehealth, even one of the good things of the only good thing I think of this time is that we have more virtual connection as far as an accessibility to care that way. Because, it's a little more convenient when you have the baby in the house and you don't have to make arrangements for bringing them somewhere or doing something. So it actually, you do have that option with a lot of providers. So really it's about speaking up. Therapy is always the first mainstay of treatment. I think everyone can use a therapist. I talk to my patients about that open and honestly, and at different points in their life, and it's just a neutral person who's skilled and can help you. Okay, they're not biased, and I really don't think the stigma needs to go away. Everybody really could use help from time to time. So I really hope that this encourages you, especially if you're in that postpartum period and you're feeling, okay, maybe I don't feel quite myself. Maybe I am suffering from this. I've had close family members and friends, colleagues go through this and then realize a year later, actually, I was very depressed in my last pregnancy, and this pregnancy is so much different, or vice versa, and being afraid to speak up about it. So I really, really, I'm passionate about this and hope that you feel empowered to speak to your providers. And I think that's the end of our time for questions. The next question I will discuss in the lactation section. So we will take a 5-minute break. Thank you so much, Dr. Menken. I really appreciate it. Thank you, Lori, for coming on early. Sorry to bring you on, but I appreciate it because a lot of the topics are intertwined. So I really appreciate you jumping on, and we will, if it's okay with you, Dr. Menken, we'll include your card or a copy of your contact information in the stuff with PSI as well.
And thank you so much for recognizing this day. I know it's a lot to pull together an event like this, but thank you, Dr. Parisi, on this special day. Yeah.
Thank you. Thank you so much. And thank you to the students. You really, really are doing a great job. We appreciate it.
Yeah.
Okay, so we'll take 5. It's 12:09. We'll come back at 12:14. Our student presenters for the breastfeeding topic can begin.
Okay, great. Welcome, everybody. My name is Kate. I'm also a first-year medical student, and we will begin talking about breastfeeding. Let's just make sure this works. Okay. As a brief introduction, breastfeeding is the process of feeding a mother's breast milk to her infant, and this can happen either directly from the breast, or it can happen by pumping out the milk from the breast into a bottle to feed the infant. Breastfeeding is the best source of nutrition for most infants. It provides infants with essential calories, vitamins, minerals, and other nutrients that are needed for optimal growth and development. In addition, breastfeeding provides benefits to both the infant and the mother. So some benefits for infants. So it has been shown that breastfeeding can offer an opportunity for the infant to bond with the mother. It's also been shown that skin-to-skin contact with the mother and suckling have been shown to have physical and emotional benefits for the infants. It's also been shown to help build and support the infant's immune system. And in addition, it has been shown to reduce the risk of certain health conditions, including the following: asthma, obesity, diabetes, allergies, something called sudden infant death syndrome, middle ear infections, bronchiolitis, pneumonia, RSV, some GI disorders like IBS and Crohn's disease, along with other diseases. And again, more research can always be done. For benefits to mothers, it also reduces the risk of certain diseases. In mothers, these diseases include high blood pressure, type 2 diabetes, ovarian cancer, and breast cancer. Breastfeeding also makes it easier for mothers to lose weight they gained during pregnancy. In addition, it can help reduce cholesterol. And breastfeeding also triggers the release of a hormone called oxytocin, which helps the uterus return to normal size more quickly after childbirth. And this may also decrease the amount of bleeding experienced after birth. So for the breastfeeding recommendations, the American Academy of Pediatrics recommends only breast milk for the infant for the first 6 months after birth. And then they recommend slowly beginning to introduce solid foods that may be recommended by the pediatrician while continuing to breastfeed for as long as is desired by the mother and the baby. So when can breastfeeding start? Most healthy newborns are ready to breastfeed within 1 hour after birth. And in order to help them get ready, it's been shown that holding the newborn directly against bare skin and keeping the newborn nearby can help encourage them to start breastfeeding. So I know we've been talking about all the benefits to breastfeeding, but there are some situations where women should not breastfeed. A lot of these situations occur when mothers are taking certain medications. These medications include antiretroviral medications used for HIV or AIDS, estrogen-containing birth controls, as were mentioned earlier in the session, cancer chemotherapy drugs, illegal drugs, certain migraine medications, some mood stabilizers, some sleep aid medications, and mothers undergoing radiation therapy should also not breastfeed. And in regards to certain illnesses and conditions, mothers with HIV infection or an infection called T-cell lymphotrophic virus type 1 or type 2, or if mothers have untreated active tuberculosis, they should also not breastfeed. Women should also not breastfeed in situations where their infants have a rare metabolic disorder called galactosemia. Okay. And then, so how to prepare for breastfeeding. So you can talk to your OBGYN about local breastfeeding classes. You can choose a lactation consultant. The International Board of Lactation Consultant Examiners is listed, and there will be more resources. You should feel free to discuss any breastfeeding challenges that you might experience with your OBGYN, and you can ask in advance if you have any health conditions that may make it harder for you to breastfeed. In regards to getting a breast pump, you can often obtain one through insurance companies, which would likely be covered with a prescription. And it's important to understand that even though there are benefits to breastfeeding, not every woman is able to breastfeed regardless of preparation. And I think now I'll turn it over to Katie.
Okay, so there's some common challenges with breastfeeding. So it's important to keep in mind that it can take time for both you and your baby to learn how to breastfeed. Many women experience these challenges, and these can include inadequate milk supply or oversupply of milk, difficulty with latching, pain while breastfeeding, infection, feeling unsupported or judged by others by your choice to breastfeed. And if you do experience any of these challenges while breastfeeding, please reach out to your OB or lactation consultant. As well, talking to other mothers may help, and you may be able to take a breastfeeding class or join a breastfeeding support group. So now we'll talk about vitamin D supplementation. So while breast milk does provide most of the nutrients the infant needs, it doesn't provide infants with adequate vitamin D. The American Academy of Pediatrics currently recommends 400 IU of vitamin D daily for infants, and breast milk contains 25 IU of vitamin D per liter. Therefore, vitamin D supplementation is required. And if you do have questions about how much to supplement and how to do that, please talk to your pediatrician, your OB, or your lactation consultant, and they can provide more information for you. And then if an infant is fed through a vitamin D fortified infant formula and consumes at least 4 cups a day, then you don't need to supplement with vitamin D. So types of food that you should be eating while breastfeeding. So your body does need an extra 450 to 500 extra calories per day to make breast milk for your baby. So if your weight is within normal range, you should be intaking about 2,500 total calories per day. In addition, you should be getting at least 1,000 milligrams of calcium per day, and that can be obtained with food. It's also recommended that you eat fish and seafood about 2 to 3 times a week, but avoid eating fish with high mercury levels. So you should not be eating shark, swordfish, king mackerel, or tilefish, and then limit albacore tuna to 6 ounces per week. And then if you do eat fish caught in local waters, then it's important to check for advisories about mercury levels and other pollutants. And then if there isn't information available, limit your intake of that fish to 6 ounces per week, and then don't eat additional fish that week. And then it's also important to drink plenty of fluids. So storing and preparing breast milk, the CDC offers guidelines and recommendations for proper storage and preparation of breast milk. And so these guidelines include expressing and handling breast milk, storage of breast milk, thawing and feeding expressed breast milk, and then these guidelines can be found on the CDC website listed here. And so how can a partner support in the breastfeeding process? So the partner can bring the baby to the mother for feedings, burp and change the baby after the feedings, rock and cuddle and rock the baby to sleep. And then if the mother pumps her breast, then you can help feed the baby. So caffeine and alcohol during breastfeeding. With caffeine, drinking moderate amounts of caffeine, which is about 200 milligrams a day, will most likely not affect your baby. Something to keep in mind, though, is that newborns and preterm infants are more sensitive to the effects of caffeine. So if you do have if it's the first few days after a baby is born, or if you have a preterm infant, then you might want to consider consuming a lower amount of caffeine. In regards to alcohol, if you want to have an occasional alcoholic drink, it's important to wait at least 2 hours after a single drink to breastfeed. And so that might look like drinking an occasional glass of wine directly after breastfeeding. And then by the time that it's time for the next feeding, you should, your body should have, it should be out of your, most of it should be out of your system by the time it's the next feeding. And then there's no need to express or discard your milk. And then, however, regularly drinking more than 2 drinks per day may be harmful to your baby and could cause drowsiness, weakness, and abnormal weight gain. Medication during breastfeeding. So most medications are safe to take while breastfeeding. However, some medications can be passed to your baby in the breast milk. And so if you do need to take medications while breastfeeding, please discuss this with your healthcare provider as well as your baby's healthcare provider. And in terms of birth control, which was mentioned earlier this morning, there are birth control methods available that can be used while breastfeeding, but please again discuss this with your healthcare team, as there is some concern, and there's some birth control options such as hormonal birth controls that could decrease your milk supply. And so if you do start using a hormonal birth control method and your milk supply decreases, you should also discuss this with your healthcare provider. Drugs and smoking during breastfeeding. So smoking can decrease the milk supply, and it can make it more difficult for the infant to gain weight. And secondhand smoke can also be harmful to infants and children, and this can increase the risk for allergies, asthma, and SIDS. And illegal drugs can also harm your baby, and marijuana is discouraged during breastfeeding. And if you do need help stopping drug use, please talk to your healthcare provider. And so with formula feeding, again, some women may choose or may need to formula feed their infants. And so some guidance about the amount and schedule of formula feeding and choosing formula can be found at healthychildren.org. They'll provide the information. And formula can also be expensive. And so if you do need help paying for formula, you may be eligible through Women, Infants, and Children for assistance in paying for that formula. So some key takeaways is If possible, breastfeeding is the recommended method of feeding your infant. However, breastfeeding can be challenging and may take time. And breastfeeding may not be possible for everyone, even with the best preparation. And there are many ways to feed your baby. If you are struggling with breastfeeding, please reach out and professionals can help you figure out the best way for you. And then here are some additional resources. You'll be provided with these slides. And so if you'd like additional resources, you can look at them here. And then our references.
Thank you both. That was very well done. And breastfeeding is a very important topic to speak about, and a lot of questions can arise. Even as obstetricians, sometimes we struggle because it's not our expertise. So I have Lori on speed dial at all times, and I call her quite frequently. And she's been an excellent support to myself and my patients. So we'll open up the floor to Lori to share some of her thoughts. And then we do have a question in the chat. If anybody has any more, feel free to send them along my way so we can ask Lori during this time.
Can you hear me?
Yes.
Okay. Kind of a funny segue from what Dr. Parisi just said. She did call me one time while I was at Costco. And when I'm on the phone with patients, I'm often using my hands and my, by my breast. And I didn't think that was the best thing to do at Costco. So we did have to, reconvene later on to chat about that. But yes, we do discuss things periodically. That was an awesome job to Zoe and Katie. I know it's really hard to do all that research and get it together in such a concise way. And it was really awesome. So I thank you for all that you did with that. And as they so nicely pointed out, breast milk is the best source of nutrition for most infants and protects against a lot of illnesses, which brings me to a very important topic for right now, which is COVID. Obviously, it's been kind of, front and center for almost the last year. And I just have to say that the information about COVID and breastfeeding and maternal child health in general changes, I don't want to say weekly, but at least monthly now with all the research that's come out. So even regardless of what we talk about right now, you'd still have to speak to your obstetrician and pediatrician at the time of delivery. Masks are essential in the hospital and everywhere else, and probably hand washing is the single most important thing we can do. So if a mom comes to the hospital and she tests positive for COVID, breastfeeding is still recommended. If mom is not feeling well or is uncomfortable about the idea of having her baby with her, we can provide mom with a pump, and a healthy person, whether it's the partner or a grandmother or just one of the nursing staff, that milk can be given to the baby because of all the protective benefits. And the research that we currently have does not show that the virus passes through the breast milk. And so the baby, if the baby gets COVID, it's not likely to have been because of the breast milk. If anything, the breast milk has antiviral and antibacterial components, so that should help to protect the baby. So if there's, any kind of confusion or ambiguity, that would be something that would be dealt with individually at whatever hospital you're delivering at by speaking to your pediatrician and your obstetrician. And I know that Dr. Parisi mentioned that there's not much positive about this COVID pandemic. And I totally agree. It's been, kind of a hard thing to live with for all these months, but I'm an optimist by nature. And one of the things that I have found to be a silver lining, and I have had validated by many patients, particularly those who've had children before, the fact that we have no visitors at the hospital has actually helped foster a more comfortable environment for breastfeeding. Moms are not worried that their brother, their father, their boss, their coworker, their neighbor is going to come in and interrupt them. And I actually did have one mom say to me, breastfeeding didn't go so well the first time, and I think I didn't get as much help in the hospital as I should have, and that was offered to me. But I kept saying, no, I can't breastfeed. My father's coming. They'll be here soon. Well, what's soon? Are they in the elevator or are they leaving their house? What is soon? And so many feedings were delayed. And there's only so many feedings you have the opportunity to get assistance with at the hospital. So for every one that you don't do is that much less help that you're able to get. And so I think knowing that it's really only the nurses or your doctor that are going to come into the room really makes it feel like such a safe environment for you to breastfeed, to bear your breast, to do things that might be otherwise uncomfortable in different situations. So I'm, like I said, I'm an optimist, and I like to look at that as one of the benefits. We do have a lot of protocols in place at Mountainside to facilitate the breastfeeding process, beginning as either Katie or Zoe mentioned, skin to skin, which has been shown to be so helpful. We put baby skin to skin right after birth. It has been shown to increase milk supply by up to 30% in some moms, orient mom to breastfeeding, orient baby to breastfeeding, because incidentally, the colostrum, which is the early milk, smells like amniotic fluid, which is what the baby has been sensing all those months. So putting the baby skin to skin helps with that. Also decreases crying because it decreases the stress hormone. So there's many, many benefits. It's actually been thought that skin to skin is actually something that should happen a lot for the first 3 months after delivery, which some researchers have called the fourth trimester, which I know wouldn't be tri, it would be quad, but it is a continuation of the pregnancy. So as much skin to skin as you can do, that would be an awesome thing. We do provide assistance right after delivery with breastfeeding. Babies are born with what's called breast-seeking behavior. It's not hunger. They're being fed right up until the minute that umbilical cord is cut. So they're not born hungry, but they're born with that typical mammalian behavior that's just a reflex, looking for a teat to latch onto to feed. So it's breast-seeking behavior, it's not hunger. And we try to work with that and get that baby to latch within the first hour, hour and a half. I don't want anybody to feel that anything is lost if that first attempt or the first 2 attempts don't work out. We've got other tricks up our sleeve, but certainly pat yourself on the back. And I know it kind of boosts your confidence if the baby does latch in those earliest minutes to hours. We also try to delay the bath. The bath seems to wipe the baby out, makes them kind of tired and may chill them. So we delay the bath. Also, some of the amniotic fluid that's on the baby's hands can help them track their way to the breast, because remember, that scent is something that they've been kind of smelling for a while. So we try to delay the bath. It's not that the nurses are lazy or they don't want to give a bath, because I've heard family members say that over the years. It's just a really good thing to do, and it's evidence-based that we do delay it. We are giving a bath maybe a little bit sooner than we might have before because of COVID. We just want to, minimize any exposure to anything, but we still will have an attempt or 2 or 3 of breastfeeding before we worry about giving a bath. Let's see if that's pretty much what I wanted to make sure that I covered with you. I'm not sure if there's anything else that any of you have questions about that I could help with. It's a topic that I'm obviously passionate about, as Dr. Parisi knows. So to be given 5 or 10 minutes to say something is really kind of difficult. But fortunately, Katie and Zoe paved the way by having been so complete in their presentation. So I'm happy to answer some questions if you have any.
So we have a few actually. One of the first one is, can diabetes type 1 slow down lactation, especially in the case where the mother is having lows or highs, so hypoglycemia or hyperglycemia?
There is some evidence that type 1 diabetes may delay the milk coming in. Moms may struggle a little bit more with milk supply, but I've seen plenty of people with type 1 diabetes ultimately do very well with breastfeeding. It may just get off to a little bit slower start. And if, the more well-controlled mom is, certainly the better it is for all involved.
As a follow-up to that, have you found that patients who are on their own insulin pumps and managing their own pumps, is that fine for them to use in breastfeeding?
Yes, I have not found that to be a problem.
Right. Okay. Very good. That's what I thought as well. The other question, how soon during the last trimester of pregnancy should one reach out to a lactation specialist for breastfeeding support before giving birth?
Unless it's identified that mom has some sort of a physical issue that may make breastfeeding more difficult, there's really not a reason you have to get an antepartum visit with a lactation consultant. Some insurance companies are paying for visits, and if you're entitled to one, and they can suggest somebody. We do also have a list of resources of people in the area who are doing telehealth. So it's not an essential thing, but as the students pointed out, if there is a particular concern and you've addressed it with your OB and it is, agreed upon that maybe an antepartum visit would be helpful, I would say, 4 to 6 weeks before might be a good time to reach out, but it's certainly not an essential thing that people need to do.
Yeah, I think it's really important to consider taking a breastfeeding class. Lori mentioned to me the other day that she gets people from all over the state taking her class, and it's very informative. So that I think the best time, at least what I tell my patients, is to think about it in the third trimester, like the earlier side of the third trimester, so that they, just in case they deliver a little bit early, but you don't want to do it too early in the pregnancy because you may forget some of the points and may need a refresher. But I think probably, and you can correct me if I'm wrong, Lori, I think that probably once you hit the third trimester, you can start looking into taking a class, and we do offer them at Mountainside. So I think it's important. And you can also speak to your family and your friends about their experiences. They don't let anyone pressure you, because everybody is different. Some women, pumping works for them. Some women, a combination of breast milk and formula work for them. Some women, exclusive breast milk works for them because they make a lot. So you really have to find and get into your rhythm, and it may take some time. But we do try to push breastfeeding, particularly for the colostrum and all the health benefits for the baby, and really try not to get discouraged. Like, we will be also here to support you. And there are some, Lori, can you maybe touch on some of the better supplements you should consider or what women can do to enhance their breast milk, rather than, because there's a lot of like fads and a lot of companies out there, and I'm sure they're not all created equally.
Right. Well, unfortunately, a lot of the galactagogues, which are herbs that have been shown to potentially increase milk supply, are not something that should just be routinely taken. Basically, if it ain't broke, don't fix it. So don't introduce something into your body that may cause issues if you don't have an issue that's requiring its use. There is a lot of evidence that oatmeal is a good thing for helping with increased milk supply. And it's certainly a good and easy food. It helps with mom's cholesterol. It's a filling kind of a breakfast. So that certainly would be something that you could consider. Plenty of fluid. You want to drink to thirst. You do not need to drown yourself in fluid, but probably an 8-ounce glass of something to drink each time you sit down to feed can help with milk supply. And if there really is a struggle, you could reach out to the pediatrician and or a lactation consultant. So on an individual basis, it can be suggested. But I mean, people who have hypothyroidism and various allergies should not be taking some of these herbs and supplements. So it's not something that just because your sister or your neighbor did it, that it's necessarily something you should consider for yourself without seeking guidance in an individual kind of way.
Thank you. The next participant said, I thought that breastfeeding alone for the first months was enough for the baby. Do they really need additional vitamin D supplements? I think this participant is referring to, does the mother need to be supplementing? I'm not
I do believe that most people have a vitamin D deficiency, but as far as the baby does need the 400 IUs of vitamin D supplement, because it is not contained in breast milk. So that is something that it's a good number of years that the American Academy of Pediatrics has been recommending that. And as far as mom's own vitamin D, probably the best way to know whether you need it is just to have a vitamin D level drawn. And probably it's going to be low. That's what we're finding with most people.
Right. You need the sunlight to convert vitamin D into a usable form. And in the Northeast, especially during the winter months, we're not really getting that much of it. So, most of the patients are vitamin D deficient, and a lot of the prenatal vitamins don't contain vitamin D at all, or just a little bit. So you can look at the ingredients in your prenatal vitamin or discuss that with your obstetrician. Also, you should be continuing your prenatal vitamin postpartum and while breastfeeding as well. Someone did ask if you teach at Mountainside. Yes, Lori does teach at Mountainside. There are 2 other lactation consultants as well. And Lori and Tish started the program, you said like 20 years ago, right?
22, yes.
That's amazing. So they teach, and they also round on all of the patients as well. So just as your obstetrician will, just as the pediatrician will, The lactation specialist will round on all the patients and learn about what their preferences are for breastfeeding, and they'll assist. Like I've had patients who say, I only want to pump, and they don't want to latch. It is important to try to latch in the beginning and get that let down. However, some patients aren't comfortable with the idea, so they work with our lactation specialists. They've even brought their pumps in or to get the right flange size and or if they have an issue with the pump, and Lori has worked with them as well. So it's really individualized, and you have to know what your preferences are, and you may not know until you start trying and kind of get into that rhythm. So don't get discouraged.
I think one of my biggest mottos or mantra is any breast milk is better than no breast milk. So I don't ever like people to feel guilty or have anybody make them feel guilty. If your choice is not to exclusively breastfeed, or you don't, like Dr. Parisi said, want to put the baby to the breast, or you have some underlying issue that may prohibit a full milk supply, any breast milk is better than no breast milk. And I want that to be a takeaway.
That's a good segue into the next questions. I had surgery on both of my breasts to take out benign masses. I heard that it depends on the scars, that it may affect my ability to breastfeed. Any attempt I can do to breastfeed regardless of the location of the scars, or any recommended formula for the infant in the end if I cannot do it?
It really, really, really depends on the location of the incision. Whether multiple ducts in the breast were severed during the surgery. There's also a nerve that innervates the breast. And so if the incision damaged the nerve, that can prevent the message getting to the brain to help with the milk supply. So without really seeing the mom, it's impossible to predict what the issue might be with milk supply. Some moms who have had multiple incisions may be more prone to what we call plug ducts. But those are things that we would really deal with on a very individual basis. And that would be based on our assessment of where the incisions were and what damage, if any, to the nerve or ducts has occurred.
Great. And with that in mind, would you consider a breast reduction 14 years ago something that may cause issues with breastfeeding? And would that be worth getting connected with a lactation consultant beforehand, or wait until I know if there are issues?
Okay, that is the most invasive type of breast surgery that is done. And I have seen some people make a decent supply. That is definitely the type of a patient where any breast milk is better than no breast milk would be a mantra that I would repeat over and over. Depending on the type of procedure that was done, the nipple and the areola complex may have been completely removed from the breast, which does potentially cause more damage to the nerve. So we really have to watch those babies closely. I usually ask that mom, if she is trying to exclusively breastfeed, she get that baby weighed twice a week in the beginning till we can verify that there is an adequate amount of milk. And sometimes moms make enough milk for the first month or two, and then they level off. Every single case is completely different. If mom has already had a child, because there is breast development that occurs with each pregnancy. If mom's had a prior pregnancy, maybe we'll make a little bit more milk the second time around just because of the enhanced breast development from each pregnancy. So that is the type of procedure that we would really have to go in with a lot of caution. But again, any breast milk is better than no breast milk.
Right. So if you're considering breast surgery in the future, breast augmentation, breast reduction, you may want to consider waiting until you're done childbearing, or at least have a very honest conversation with your surgeon. A lot of my patients had surgery when they were very young, and they say, oh, the doctor didn't mention that. Now, I wasn't there for that conversation, and it was a long time ago, so I can't speak to that, but it definitely is on us as providers to counsel the patients appropriately and be honest. Like, there is a chance that you may have difficulty or be unable in the future to breastfeed. Some women do need to have a breast reduction because they really are in a lot of pain and can't get through their daily living. So it really is, again, I know I sound like a broken record. It's an individualized decision, but there are consequences to any potential surgery, scar tissue and the like. So, but don't get discouraged. I had a patient who had a breast reduction and an augmentation, and she exclusively breastfed. So some people are luckier than others, and we work with the lactation specialists, and you just kind of do what you can. So that was the last question. Lori, thank you so much for your time. I
problem.
really, really appreciate it. You're such a shining light at Mountainside and a huge resource to us, really, as OBGYN providers. We don't learn anything about breastfeeding in residency, unfortunately. And, you know, I was at, you know, where I trained, it was a wonderful hospital, but I never even got to know the lactation people because they weren't around. So just knowing, like, Lori is constantly on the floor, rounding on the patients, looking and digging into their history to see if there's some underlying physiologic condition, because she's also a nurse. So I really, you know, it's a huge asset, and it's really nice to have the medical team behind for all the patients. Like, you have your whole comprehensive team. So we're always working for you. So thank you so much, Lori, for taking
No
your
problem.
Saturday to help us.
Happy to help.
Okay, definitely. Then you all should consider her class.
And
All
please
right.
show me your face if you do.
Yes, if you take her class, you need to show her face because it's an interactive session. But so we're going to move on to the last portion, which is also a very special portion. I'm going to welcome Kim Chabria. Hi, Kim. So Kim is a patient of mine who I love very much. And she is a wonderful person. And I really, especially being you know, just recently delivering, I think this is, we're very lucky to have you here, because who better to talk about what you wish you knew before you gave birth than a mom. So we're going to do a little, Kim's going to tell us a little bit about herself, and I really appreciate your open and being open and honest. And then I'll ask a few questions, and then maybe we'll open up the floor if we have the time.
Great. Thank you, Dr. Parisi. So yes, I'm Kim Chabria. I have 2 children. I started a little later in life. My first child, I had my daughter when I was 37, and my second I had 9 weeks ago. He's a little boy. My journey has been one that maybe some people can relate with, and maybe give some, if you're starting off a little later in life, for me, I was always focusing on work. I tried to meet people. But for me, my family, my love and my family life started a little later in life. At 36, I met my husband. 4 months later, we got engaged. 2 months after that, we moved. A few months after that, I found out I was pregnant. I got married. We also, during that whole time, I started a new job. So it was a lot in a little bit of time, but it's been quite a ride, and I wouldn't change it.
So what was it like to have a baby in the hospital during the COVID pandemic, Kim?
Yeah, it was definitely different. Even pre-delivery, my husband couldn't go to many or any of the appointments, so I felt a little bit alone in this whole process. After I gave birth to Lucas, my son, I was only allowed to have one person visit me, and so that was my husband. So he was the only one that could come and check on me and stay with me, besides from Dr. Parisi and the nurses. And also, my son had heart problems. His heart rate was really fast, so we had to do an emergency C-section. So besides COVID and having only my husband being able to visit me, my son was actually at Hackensack while I was at Mountainside in an incube, getting treated and monitored for all of to make sure that he was okay, make sure that his heart rate got better, which it has, and he's fine now. But it was definitely I felt alone for sure, and wearing mask and just being extra safe, it just kind of added another layer to the whole experience, I think, too.
So sometimes that can happen where a patient delivers, and if the baby has the neonatologist determines that the baby requires a level of care that is a little bit higher or needs multiple people, then the baby may have to be transferred to Hackensack, our larger sister hospital, which is a tertiary care facility. So Lucas stayed for two days, right? 2 days?
In
So
3 days, yeah.
3 days, 3 days. So sometimes this does occur, and it is very difficult for a mom who's been carrying a baby for 9 months to be separated quickly. So that definitely can happen. And Kim was super strong and, you know, pushed through, and I really commend her on that. Do you think that, what was I going to say is, did you take any classes or anything during your pregnancies to prepare you for like what to expect?
So with my first, with my daughter, my husband and I took a breathing class, and it was good. But that was the only real class that we took to get ready for the delivery. I knew I was having a C-section with her, so I did not take any Lamaze classes or anything like that. And in terms of breastfeeding, I did breastfeed both of them for a month and a half, which was, to me, you know, both of them were big babies and they love to eat like their mom. But for me, I think the breastfeeding, and I supplemented with formula for a month and a half, and that worked best for me. So I did also take a lactation, I talked to a lactation specialist at the hospital, and just most recently, the one that I spoke with was fantastic. I definitely recommend talking to a lactation specialist. They know so much and can really help you and show you how to do it. And even if you are on to your second or third or fourth child, I think you'd always learn something new as well, because you don't always remember everything.
Great. What is the must-have baby product that a woman should put on their registry, and why?
So I love fancy things, but I'm also pretty practical, especially after my second one. For me, diapers, bottles, having a small little seat that you could put your baby down on while you cook or clean or just sit down and watch TV is great. Also, I think a humidifier, and one of those, if they have a cold, you can't really give a baby anything for a cold. So getting one of those snot suckers, I don't know if everyone knows it, but that it's a snot sucker nasal aspirator, and you suck the boogers right out of
the nose free.
Yeah. I mean, that thing is amazing. The baby doesn't like it, but it works. So things like that. Also onesies with zippers, not buttons, because the buttons are very hard to do, especially when you're getting up a couple times during the night and changing the baby. You don't want to be dealing with buttons. A zipper is easier. And for me too, I'm in marketing, and one of my previous clients was the Juvenile Products Manufacturing Association, JPMA, and I'll give them a little shout out. I don't work with them or have any sort of affiliation with them now, but look for baby products with the JPMA certified seal on it. That helped me, because you know that the government requires all the baby products to do have certain requirements and regulations, but they go a step further to making sure that the products that you buy are safe. So look for that little JPMA seal. I have that on they have on mattresses and cribs, and that's also something that I look for when I was putting things on my registry as well.
Great. So Kim did allow me to talk a little bit about her care. She gave me permission, and at the initial postpartum visit at the incision check, we found that her blood pressure was elevated and she did have a headache. So she was actually readmitted with postpartum pre-eclampsia. She didn't have any blood pressure issues throughout the entire pregnancy. So that can still happen up to 6 weeks postpartum. And that's why we were stressing before how important it was to attend your early postpartum visit and to be honest with your doctor about your symptoms, and for us to monitor the vitals and see how you're feeling. So again, Kim, I'm sure it was difficult to be readmitted to the hospital. Did you want to touch on that a little bit?
Yeah, I think, one of the things is that we're talking about today is what you wish you knew before in this fourth trimester. And I mean, I never had high blood pressure. I never had any sort of, real problems in terms of heart rate or anything like that. And when I went to my doctor's visit with Dr. Parisi and found that out, that I had high blood pressure and low heart rate, it was shocking to me. And your body really does change after you have kids. And then having to go back to the hospital and being in that triage room where I found out that we had to have an emergency C-section 1 week prior with my son, it was a lot. So it probably added a bit more stress for me as well. But I'm happy that actually I was able to go. Dr. Parisi recommended not going to the emergency room and going to the labor and delivery floor again, which made me feel a little bit safer in a way. I don't know why, but I felt like I knew some of the nurses already because I had met them last week, and I knew Dr. Parisi was around to help as well. But having doctors that you can ask questions to, and the nurses, it makes a huge difference. They were very patient with me and they answered all my questions. And even if I didn't have questions, they asked questions for me because they knew that I was probably just a little bit out of it or nervous too. So that helped as well.
Great. Is there anything else you'd like to offer as a piece of advice to our new or expectant mothers?
Yeah, I mean, there's a lot, but just a couple things. I know we have 3 minutes left. Your body will definitely change. Like my stomach is still numb from my first pregnancy, and it's numb now from my second. Sleep deprivation is real. It'll cause arguments with your partner. Try to make some sort of schedule that works for you or for both of you. I do think that you will feel self-doubt. It's inevitable. You'll feel like, am I doing enough for my child? Am I doing enough for me? Am I doing enough for my partner? But you have to just try to be positive, I think. And I think earlier you talked about talking to a therapist or talking to a friend or talking to your doctor or talking to someone, a mother at daycare or whoever you feel comfortable with. I think that's really important, just to have these conversations, because not everyone feels like they should or they can, and they internalize a lot. So I think it's really important that you do talk about it. And just lastly, I think not to compare your child with others, because everyone's child is different. Everyone's journey is different. You don't know how many times I have heard that, oh, well, I potty trained my son at 1 year old. My daughter's almost 3 and she's still not potty trained. And I know she will eventually know how to use the potty, so I'm not worried about that. But just try not to get too anxious about comparing how your child is with others, because every child is different. And I think that's important too, just to remember.
Right. Thank you so much for offering your firsthand experience. I think it's invaluable. It's a really great way to wrap up the talk today. And I think, Lucas is a little boy, but a big boy, over 10 pounds. And, it just, everything with your story kind of touches on all 4 of the topics we spoke about: the importance of going to the postpartum visit, warning signs for postpartum preeclampsia, as far as just feelings of alone and feeling sad, and maybe some postpartum blues very commonly occur. And you also had the stress of Lucas's heart rate being elevated, so us having to, send him to the NICU for monitoring, and then being away from him twice in the first week and a half of delivery, and then just with breastfeeding, how, because he is so big, he consumes a lot, and you did a combination of breast milk and formula, which is perfect. Like, there's nothing to be ashamed of as far as formula. The hospitals typically give out Similac or Enfamil. You can work with your pediatricians as far as like the best thing that works for your babies, because we don't know Some babies, they're lactose intolerant. Some babies need the more gentle formula. You know, I wouldn't say don't get caught up with the hype in the beginning. Like, it's a little bit of a trial and error. And maybe you can speak to that, Kim, as well, as far as formula. You know, I think it's really about, you know, monitoring the babies, see what their weights are, see what the pediatrician has to say. There are some, I know some people use European formulas. Typically at the hospital, we try not to use the powdered formulas while the patient's in the hospital, but there are a lot of, you know, formulas out there, and the pediatricians and the lactation consultants will be able to answer your questions as well.
Yeah, I mean, 100% right. And I actually did not know this until recently, but your pediatrician will give you free samples as well. So you can ask them for some samples and they'll give it to you. So you can have trying to test some things that work best for your baby and also save some money. They give it to you. So that's what I've been doing. Lucas has been spinning up more than my daughter had ever. I gave her Similac, I gave her Enfamil, and she took it all, no spitting up. He has been spinning up more, so I've been trying to use some more of the gentle ones that are more suited for that. So yeah, I think it is trial and error, and talking to your pediatrician and finding out what they suggest and getting some samples from them as well, so you can test it.
Great. Does anyone have any questions for Kim? We do have, I would say maybe like 4 minutes or so, 3-4 minutes we can go if anybody has any questions. Otherwise, we will be wrapping up. Don't see anything in the chat. Do any of the students have any questions?
Well, I don't know if anyone has been watching the Tiger Woods documentary on HBO, but he started golfing at 9 months old. So that one thing, do not compare your kids to Tiger Woods, because you will feel like you are not doing enough for your child. That's for sure.
It's true. You will get a lot of pressures about everything, whether it comes down to getting an epidural or getting Pitocin or breaking your water or when to go in and when to go out, and the birth plans. Please make birth preferences, not plans. We can't plan for what will happen. You know, one day, the day before, I saw Kim and her baby's heart rate was normal. And when she showed up, the baby's heart rate was in the 200s. So that's why we had to do the emergency C-section. It was unexplained, and luckily Lucas is fine. It is an incidental thing that can occur. And that's why it's important that she had the maternal instinct to come in, and also she listened to the precautions that we spoke about as far as bleeding, pain, fever, contractions, leakage of fluid. Those are the things that you'll reiterate with your doctor, will reiterate with you. And you really shouldn't take anything lightly. When in doubt, speak to your provider. And really just don't let people get you down. Like, a lot of people will kind of share their opinion, or they're feeling like, oh, well, I didn't get an epidural with my child, or I didn't do this. Listen, the only trophy at the end is the healthy baby. So I really, really push that. Every patient is different, and it's really important for you to really just consider that you're doing the best you can for you and your baby, and it's not a competition with anybody else. Lori does want to say something about powdered formula, so we'll let her say that. Laura?
I'm trying to start the video here. There we go. When it was mentioned about getting samples from the pediatrician, just be careful to not use powdered formula for the first 8 to 12 weeks while the baby still has an immature immune system. Powder cannot be sterilized. So even if you're using a sterile bottle and sterile water, the product itself has a naturally containing bacteria in it. So it's really advised to not use powder, particularly if it's a preterm baby or a baby that has any kind of medical issues for the first 12 weeks, but a full-term healthy baby, 8 to 12 weeks until their immune system is mature, it's really recommended not to use powdered formula. And unfortunately, many of the pediatricians' offices do give out powder. But if you look at the the World Health Organization guidelines, it very clearly, and the CDC, it clearly advises against powder in the beginning. So I just wanted to say that.
That's good to know. I did not know that. Thank you.
See, you learned
Yep.
something.
I even thought it
Like
was
you said.
I thought it was the first 28 days. I didn't realize that when you say 8 to 12 weeks, I didn't know that, because I have colleagues who are obstetricians who use it and with the sterile water. But
I'll show you the article.
I
We have
learned
it in the
something
office.
today.
No, I'll show you the article. I have it in the office next time I see you.
I believe you. Like I said, she knows everything about breastfeeding.
Not that, but I just wanted to make sure that we were careful about what we were having people do.
Definitely. Well, Kim, thank you so much. This was wonderful. I really, really appreciate everything. And I just, really, I hope that this was helpful to everybody. We really put a lot of work into the presentation. The students, we really should give them, round of applause, because they worked very, very hard on researching these topics. Some of them, if and how medical school works is, in the beginning, you're in the classroom, and as time goes on, then you move into the clerkships and the clinical setting. So a lot of them had not even learned any of this information, and they did the research, and it was really written very well. So when they handed me the presentations, I didn't have much that I had to add to them. So I'm very impressed by all their hard work, and I'm really happy that we have student doctors that are interested in OBGYN. So really just, I hope you all enjoy the rest of your weekend, and I will be sending out the packets, the silicone bracelets, the journals, and all the information from Acog, and the great information that from PSI and that Lori provided. So you'll be receiving a little gift package, and if there's anything, and with my contact information as well, so you can always reach out to my email, which is vanessa.parisi, Parisi, at mountainsidehosp.com, and that's my work email. So I'll get back to you as soon as I can. I'm a little busy, but I promise I'll get back as soon as I can. And when it comes to medical advice, if you're currently pregnant, you really should speak to your OBGYN provider, because I never want to overstep what you're working with in the rapport that you've established with them. But I'm always happy to lend an ear and offer some advice. So I hope that you all enjoy the rest of your day. Thank you so much for participating. Bye-bye.
Bye.